May I please invite onto the dais Dr. Dayanand Babu, our esteemed examiners, Dr. Vijay Paul, Dr. Mohammed Salim, please, and the chairperson, Dr. Jane Stephen, the chairperson for the topic presentation, also on to the dais, and the examiners for the case presentation. The case presentation by Dr. Jinsha and Dr. Safwan from Lourdes Hospital, Cochin. Over to our esteemed examiners and chairperson. The first case presentation, post-lunch.
Introduce yourself and start.
Good afternoon, all. Myself, Dr. Safwan, and here is Dr. Jinsha. We are from Lourdes Hospital. We are presenting a case of epigastric lump. Mr. X, 38-year-old gentleman, driver by occupation from Ernakulam, belonging to lower middle class socioeconomic status, presented with the chief complaints of fullness in the upper abdomen for past 2 weeks and vomiting since 2 days. History of presenting illness. Patient noticed fullness in the upper abdomen 2 weeks back, associated with a dull aching pain, which is non-radiating. There is no specific aggravating and relieving factors. History of early satiety since 2 weeks. History of non-bilious, non-projectile vomiting with undigested food particles as content for past 2 days. There is no history of loss of weight or loss of appetite. No history of fever, yellowish discoloration of urine and eyes. No history of hematemesis, melena, altered bowel habits. No history of dyspepsia, bloating or bowel rolling movement. No history of any other swelling in the body. No history of abdominal trauma. Past history. History of ICU admission 3 months back for 3 days following sudden onset of upper abdominal pain and vomiting following alcohol binge. He was evaluated and diagnosed to have acute pancreatitis and managed conservatively. Later, he was shifted to ward and discharged after 1 week. No non-comorbidities, no surgical interventions in the past. Family history, no significant family history. Personal history, consumes mixed diet, normal sleep pattern, bowel and bladder habits are normal. History of consumption of alcohol daily for past 10 years, 100 to 150 ml per day with occasional binge intake. Non-smoker.
Coming to general examination, I have examined the patient with verbal consent in a well-lit room and adequate exposure. Patient is conscious, oriented and cooperative, moderately built and nourished. Weight 68 kg, height 170 cm, BMI 24 kg per meter square. ECOG performance scale 0. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pedal edema. No stigmata of chronic liver disease. Vital signs. Pulse rate is 78 per minute in the right radial artery, normal volume, regular rhythm, no radioradial or radiofemoral delay. BP 120 over 80 mm of mercury in right arm supine position. Afebrile. Respiratory rate 14 cycles per minute. Examination of abdomen. On inspection, there is a fullness present in the epigastric region which became less obvious on head raising test. Skin over the swelling normal. All the quadrants of the abdomen are moving equally with the respiration. Umbilicus, midline and inverted. No visible pulsations or peristalsis seen over the abdomen. Hernial orifices and external genitalia appear normal. No supraclavicular fossa fullness is seen. Bilateral renal angles are normal. Palpation. No local rise of temperature over the swelling. A 12 cross 10 cm non-tender, non-pulsatile, smooth surfaced firm swelling present in the epigastric region extending to the left hypochondrial region. Fingers cannot be insinuated under the costal margin. Inferior border is 2 cm above the umbilicus. Swelling is intra-abdominal. Lump is immobile and not moving with respiration. No other organomegaly. Hernial orifices and external genitalia appears normal. No renal angle tenderness. Supraclavicular regions, no enlarged lymph nodes. On percussion, liver span is 12 cm measured in mid-clavicular line. Lump is dull on percussion and it is not continuous with liver dullness. No free fluid noted. Auscultation, normal bowel sounds heard, no bruit. Perrectal examination normal. Other system examination are normal. Summary: a 38-year-old gentleman, chronic alcoholic, presented with complaints of fullness in the upper abdomen, multiple episodes of vomiting, and early satiety, with a past history of acute pancreatitis 3 months back. On examination, a 12 cross 10 centimeter non-tender, non-pulsatile, smooth surfaced, firm intra-abdominal swelling present in the epigastric region, extending to the left hypochondrial region with dull on percussion. Clinical diagnosis: pseudocyst of pancreas as a sequelae of acute pancreatitis.
Any differential diagnosis?
Cystic neoplasms of the pancreas.
So your basic primary diagnosis is only pancreas. No other diagnosis?
No, sir.
What are the differential diagnosis of epigastric mass?
Mass from the left lobe of the liver, or hydatid cyst of the liver, hydatid cyst of spleen, or pseudocyst of the pancreas, aortic aneurysm, and carcinoma stomach.
So carcinoma stomach is the last. Is it?
No.
You said loss of weight, loss of appetite, something like that you mentioned.
No history of loss of weight and loss of appetite.
No history.
What
But
is the
vomiting
type?
is there.
Sir, in
Yes,
a,
sir. Yes, sir. Vomiting also.
Vomiting is there. 2 weeks.
No, sir. Only two
Two
days
days.
vomiting.
Only 2 days. What is the importance of family history in this case?
In this case, as a diagnosis is pseudocyst of
No,
pancreas.
forget about pseudocyst. You don't know whether it is pseudocyst or not.
okay. In an epigastric swelling, several DDs are there. To rule out carcinoma of stomach, we can ask family history.
What is the importance?
Many syndromes associated with the carcinoma of stomach.
Like? Like?
Familial
Yes.
adenomatous polyposis.
Adenomatous. What is Lynch syndrome? You said many syndromes. What is Lynch?
Lynch syndrome.
What is it?
HNPC.
What is it?
Hereditary non-polyposis colonic cancers.
Have you heard of it?
Yes.
Can it be associated with stomach malignancy?
Yes, sir.
What is the importance of family history in stomach?
Gastric cancer is
Can be familial.
familial.
Can be?
Familial.
Example?
Intestinal type of gastric cancer.
Have you heard of Napoleon? Napoleon story?
Sir.
Napoleon. Have you heard of Napoleon? Yes or no?
Yes.
Eh?
Yes.
What about you?
Yes. No.
Yes, sir.
No. How Napoleon died? It's a controversy, but still
Can it run in families?
Yes, sir.
Yes.
carcinoma
That
stomach.
sir is reaching to that point only.
Yes, it is
Only
running
families.
family.
Say Napoleon story, you should know. Napoleon died of carcinoma stomach. His father, his grandfather, his 3 sisters, 1 brother, all died of carcinoma. So family history is very important. You just said not significant or something like. Is he married?
Yes, sir.
How many siblings? At least you should mention those things in family. How many siblings? Any visible gastric peristalsis for this patient?
No, sir.
No, sir.
But vomiting is there, isn't it?
Yes.
So how will you elicit visible gastric peristalsis? Patient has got vomiting, there is fullness, there is a lump. How do you elicit visible gastric peristalsis?
Ask the patient to take some amount of water,
Ah,
then inspect over the abdomen.
ah.
If
How
there is
long you will observe after water?
15.
How long you will, yes? And what you will see?
There will be peristalsis from the left side of the abdomen to right
Left
side.
to right, visible gastric peristalsis. Suppose it is not there, still you are suspecting. What is the objective test for gastric outlet obstruction? What is the objective test for?
Succussion.
Yes?
Succussion splash.
No,
Clinic,
objective.
clinically, how can you?
Objectively, how do you rule out gastric outlet obstruction? Yes?
You said
Have you heard of saline load test? Saline, which year you are?
Second.
Second year. Saline load test. Have you heard of it? Yes or no?
No.
No, sir.
No, you have to infuse 700 ml of saline and then after half an hour you aspirate. If it is more than 350 ml, that is the objective test, saline load test. So why this is pancreatic pseudocyst? That's the basic question. And then we will.
It is a 38-year-old man
Yeah.
with chronic alcoholic.
Now, clinical points in favor of
The swelling is not moving with respiration.
okay.
Um,
Yes, that is one point. Any other? What is the percussion finding
in our
over the swelling?
Dull on
dull
percussion.
non-percussion.
So normally you expect dullness or resonance in pseudocyst.
The pseudocyst is just behind the stomach. The percussion note may be.
Not maybe. It is always.
It is
of
always
course,
that present.
Can it occur in the mediastinum? Can it occur in the?
Yes, sir.
So it all depends on the situation. But your description, it is epigastric. So usually it will be retrogastric. So it will be resonant only. And there is a clinical test based on that. You know that?
Weight test.
Weight test. So that means it will be resonant. You said dull. So if it is dull, whether the dullness is continuous with liver dullness or not,
Not continuous with the rival nerve.
not continuous. You can insinuate your fingers.
Not behind the left causal margins.
You said you cannot insinuate. So some contradictory point. You said you cannot insinuate. You said it is dull. So if you cannot insinuate, if it is dull, the possibility is liver. That is why I am asking. Your clinical finding is it is a dull swelling. You cannot insinuate. So automatically the dullness is continuous with liver dullness or not?
Not continuous with the liver.
So there is a band of resonance. That case you should have mentioned. There is a band of resonance between liver dullness and this swelling. Am I right?
Yes, sir.
So because it is not moving, but the other points I am not very happy. Only point is it is not moving. So you are diagnosed and the history of so-called acute pancreatitis. Otherwise, what is the purpose of PR examination? Digital rectal examination?
For completion sake, we have done.
Completion sake.
Can,
It can be
Can be a carcinoma of stomach.
with
like in
metastasis.
your,
Now your CA stomach was your last diagnosis, isn't it?
leave alone that, Sarah has completed probably the differential diagnosis and the carcinoma stomach part. You said that it's an intra-abdominal lump, not moving with the respiration. What is the reason why it is not moving with the respiration for a pseudopancreatitis?
Usually the organs moves with the respiration will be touching the diaphragm.
For a pseudopancreatitis, what is the reason that it is not moving with the
It
respiration?
is retroperitoneal organ.
We know every lump in contact with the diaphragm should move with the respiration if it's in free space, but this may not be in. But what is the disposition of the pseudopancreatic cyst? Where is it located? And that is explaining the last.
Usually in the lesser sac of.
Where is the lesser sac? Let me ask little anatomy brushing up also along with that, because the clinical points were covered well by Bowser within a limited time. Yes.
Behind the stomach.
It is behind the stomach alone, or will you describe it in can you describe it in a sentence at least? It is very easy to describe lesser sac in a sentence alone. What is the three-dimensional disposition of lesser sac in a sentence? It is easy to say that it is below the caudate process, it is behind the lesser omentum, it is behind the stomach, and it is in the greater omentum. That's a very good sentence to describe. And that part may not move because is it retroperitoneal or intraperitoneal? Totally the lesser sac? It is intraperitoneal. But only at the anterior border of the pancreas, it comes and ensheathes, and then there is a mesocolon, and inside the mesocolon, transverse mesocolon, mesocolon, you have 4 layers. Originally, between the 2 layers, there is a potential space that also includes the lesser. That will not transmit any movement. Can pseudopancreatitis be still continuous with the liver dullness?
Sir,
Possible or not?
possible.
Will you expect always a zone of presence? No. It is
No,
not.
sir.
And the better term for that, as Sir was rightly pointing out, it is not dull, but it may be sometimes impaired dullness instead of impaired resonance. Okay, outlet obstruction, Sir was asking about the volume respected the clinical scientist. But for that, other than that, what is outlet obstruction features which you expect?
Vomiting,
Gastric outlet obstruction. How will it be typically? What are the causes of gastric outlet obstruction generally?
pyloric stenosis,
One thing, acquired pyloric stenosis, benign pyloric stenosis.
benign
we should
pyloric
say.
stenosis.
Next, when there is a benign, there should be a malignant. What is malignant? The distal carcinoma pancreas, carcinoma stomach. Then other than that,
Mm,
Head of time.
Any obstruction due to CA head of
from birth onwards, can you narrate or not?
congenital hypertrophic pyloric stenosis, then duodenal
Annular.
annular pancreas,
Yes, yes.
duodenal atresia.
Atresia.
Atresia. Or to that, even you can include superior mesenteric carcinoma onwards, but that is not typically gastric outlet. Now, can a carcinoma stomach be presenting and confusing you with the pseudopancreatitis? Just like a subtle differential diagnosis. It doesn't move with the respiration at all. Can you get it or not? Can a carcinoma stomach, when there is loss of movement of intra-abdominal, what's your suspicion?
Linitis plastic.
No, linitis plastica may not present with a lump sometimes. You may not be able to.
Fixed to the underlying.
Sorry?
If it is fixed to the underlying structure.
Local region.
It's a sign of invasion. And many a times it decides that it is practically radically not inoperable, unless by the adjuvant prosthesis. Now, cardiac side, the proximal and the distal stomach malignancy. What are the essential differences in presentation?
Usually proximal and usually the presentation will be early vomiting, dysphagia, and immediately after the food intake, the patient will start vomiting.
How do you term it? What is the best
Projectile.
term?
Projected.
Huh?
Projectile.
Projectile in proximal gastric. That's the term regurgitation. Regurgitation is more common in distal or in more proximal?
Proximal.
Always. What are the other differential? There's one differential diagnosis where you get a huge big stomach with acute distension and you get something copious amount of fluid coming out as regurgitation. What is that condition within the short, if the history is very short, can be possible in an alcoholic even?
Acute gastric dilatation.
Acute gastric dilatation. What is the description typically of acute gastric dilatation fluid?
Sir,
There's a beautiful description in Hamilton Bailey's clinical methods about the particular fluid copy ground as if something is suspended in that. Can you tell it? The storm water of a peat-laden stream. If you keep it in a stream, in a test tube. So that's acute in dilatation, but you get regurgitation and you get a total fullness, like some days confusing, but the history is very short. So he said between proximal and dilatation. Then I have come to investigation. Go on to investigation. You can go on to investigation.
Investigation.
How do you want to manage this patient?
First blood routine. Then we are
Blood routine will help. See, generally, we classify investigations into diagnostic investigation. Then if it is malignancy, staging investigation. Then other investigations for anesthesia and surgery.
To,
So
di-
diagnostic investigations you tell.
to diagnose, first we have go for ultrasound abdomen. And
How it will help. So you
In ultrasound abdomen, first we have to look for the organ of the origin from where the swelling comes in. Then you can also look for if ours was pseudocyst of the pancreas. So we can also look for any duct pathology is there, CBD, whether CBD is dilated or not, whether there is CBD stones, whether there is gallstones are there, and also we can look for the whether the pancreas is bulky or edematous, and any splenic vein thrombosis is there. And applying color Doppler, we can also look for the vascular complications like pseudoaneurysm.
In your patient who's a chronic alcoholic, ultrasound can also tell you something more about the liver
sir.
also.
If the patient having chronic liver disease,
Collaterals.
collaterals.
Okay, then after ultrasound,
CT abdomen to know the thickness of the pseudocyst and any ductal communication.
what was the last, when was the last episode of acute abdominal pain this patient had?
3 months back.
Why did I ask?
There is a time gap between the acute episode and to form a pseudocyst.
Otherwise, before that, it's called
Acute peripancreatic fluid collection.
So did your CT, what else will the contrast CT tell you? We take your diagnosis as pseudocyst of the pancreas. What other information does your contrast CT tell you?
Any pseudoaneurysm or portal vein thrombosis
Very good.
or any necrosis of the pancreas, we can also see in CT. I mean contrast enhanced CT.
of necrosis,
Sir,
Waldorf necrosis.
encapsulate.
It develops after 4 weeks after the episode of acute necrotizing pancreatitis. If during the episode of acute necrotizing pancreatitis, if there is acute necrotic collection, and during the course of 4 weeks, there will form wall and form Waldorf necrosis.
Will you do a upper GI endoscopy for this patient?
Yes, sir.
Yes. If there is any portal vein thrombosis, it causes portal hypertension and varices in the stomach.
Over the conventional imageology, what's the advantage of endoscopy?
Endoscopic ultrasound.
Um, Sir, one thing from upper GI endoscopy, we can rule out any varices in the stomach, and the other thing, endoscopic ultrasound by doing an
Carcinoma stomach is concerned. What's the advantage of endoscopy over?
we can take a biopsy.
You can do endoscopic
Only to take biopsy, or you will have some other
endoscopic dilatation can
Do dilatation in carcinoma stomach.
no, sir. As a palliative measure,
You compare between endoscopy and other studies. So for certain malignancy, endoscopy is preferable. For certain malignancy, biopsy is inevitable. Wherever there is doubt, you may have to take maybe 6 weeks or so in endoscopical, etc. At least.
Early gastric cancer, we can do submucosal resection in carcinoma stomach.
So
by doing-
endoscopy will help you for linitis plastic and submucosal lesions, or contrast study will help you. That is the question.
Endoscopy will help.
How? Endoscopy may miss a linitis plastic. That's the reason. You can take blind biopsy on it. Whereas structurative lesions, distal, not that very narrow, proximal or distal, all those may be missed in endoscopy, but then other contrast. Is there any simple investigation other than CT contrast, all those things, to delineate between the pseudopancreatic cyst and carcinoma? If you are in a remote area, you have no CT, no imageology. But you have preliminary setup of contrast. What will you do?
contrast X-ray can be taken, lateral X-ray can be
Which
taken.
X-ray? Which X-ray?
Lateral view.
Lateral view, preferably of swallow, swallow material, anything like that. That will help you to know the disposition
there is-
between the stomach and the opacity with the contrast lumen and the base behind.
How do you proceed? Your CT, there is a cyst, retrogastric cystic lesion is there, maybe pseudocyst. How do you proceed?
For our patient, we have done cystogastrostomy,
No.
drainage procedure.
So drainage is the only option.
No, we can go for conservative also.
Size is 4 centimeter.
What are the indication for drainage in a case of pseudocystic pancreas?
If it is more than 6 centimeter in size and more than 6 week duration, and if the patient is symptomatic,
6 weeks,
to mature the wall of pseudocyst. Otherwise, the sutures will not hold.
which is
When we doing cystogastrostomy, the suture will be in between the cystic wall and the posterior wall of the stomach. If the cyst wall is not much matured, the suture will not hold.
you are planning only cystogastrostomy.
What is the name of cystogastrostomy, sir?
Juarez operation.
What?
Juarez operation.
Apart from anastomosis, what all things you will do during your cystogastrostomy? You will make
We
an
can take aspirate of the fluid for
for what?
cytology.
For what?
For cytology,
For cytology.
we can do CEA level in fluid
CEA.
to rule
Any
out.
other thing?
Sir,
CEA. One more.
News.
cyst wall biopsy can be taken.
This biopsy is different. We are talking about fluid. One more
Amylase.
thing.
Amylase.
You should be very clear. You should be. So you do amylase, CEA, all those things you do. And biopsy. Why biopsy?
If there is any suspicion of cystic neoplasm,
Not suspicion. You have to rule out a malignancy in all cases. How it is done? What is the anastomosis? Can you do it without surgery? Your cystogastrostomy,
endoscopy can be.
endoscopic, any other method? Endoscopic cystogastrostomy, any other method?
Percutaneous transgastric or
Percutaneous,
transduodenal.
any other method? Can do laparoscopy. So here, what was done according to you?
Open surgical cystogastrostomy.
So how the cyst is approached?
Midline laparotomy incision, then anterior wall of the stomach, we have done gastrotomy, and reaching the posterior wall of stomach, longitudinal incision made, and drainage of the fluid done, and cyst wall is sutured with the posterior wall of the stomach by doing an hemostatic interrupted sutures.
Suppose, will the food material go to the cyst after this?
No, sir.
I,
Because after drainage of the cyst, usually the cyst will be collapsed.
so nothing will happen. Any role for
Pressure
ERCP?
difference will be.
Any role for ERCP?
Yes, yes, sir.
ERCP, any role?
Yes, sir. If the cyst is connected to the pancreatic duct, then we can try ERCP with stenting of the duct.
ERCP, yeah.
If the size of the swelling is getting reduced after a period of observation, then we can go for
So when he was asking endoscopy, I was thinking that you will mention the role of ERCP, standing, all those things. Right? I think you should know the complications of acute pancreatitis thoroughly. What is vault of necrosis? What is the definition of pseudocyst?
It is a pancreatic juice-rich fluid collection with a granulated or fibrous tissue capsule. Granulation tissue with encapsulated pancreatic juice fluid collection.
What is the wall?
Fibrous tissue or
With granulation.
granulation tissue.
Definition is, should give correct definitions.
Thank you.
Thank you, sir.
Vast, very vast topic, cannot be covered, but we have to keep up the time, so yeah. Anyway, good, done well, good presentation.
Thank you to both of you. May I please call on Dr. Shabir Ali, please. So I request the esteemed panel to remain on the dais, please. Thank you. Dr. Shabir Ali, please.
Good afternoon, respected teachers and dear colleagues. This topic, I think we have already started discussion on pancreatitis and its complications. So I'll go through what are the possible complications of acute pancreatitis and what surgeon should know, surgeon's perspective. And nowadays, it's not only surgeon. Surgeon has only a very limited role in some of the complications. But there are other, I'll present you that multidisciplinary approach in acute pancreatitis complication management. Going on to the introduction, some of the key things you should know, like severe acute pancreatitis is accounts for about 10 to 15% of total pancreatitis. Rest will be mild acute pancreatitis. Mortality of those who are progressing to severe acute pancreatitis is around 10 to 40%. Its average reported around 20-30%. 20 to 30% of this severe acute pancreatitis will invariably get in necrosis and antecedent complications like infection. And 40% of the mortality related to the pancreatitis is from infected pancreatic necrosis. The commoner, like 60%, mortality is related to the organ failure in the first phase. Mortality of infected pancreatic necrosis and complications again around 30%. The issue of pancreatic necrosis and related complication is that it causes prolonged morbidity, long hospital stay, multiple hospital admissions, and it carries a significant financial burden, especially in our private setup. Some of the definitions which you should know, I think students have already answered. Mild means it's an interstitial edematous pancreatitis without any organ failure or local complications. Severe is those who have a persistent organ failure that is lasting for more than 48 hours, or those who are developing local complications. Local complications without organ failure or a transient organ failure, we call them as moderately severe. Early phase, again, we have mentioned this. There are two, you should know there are two phases of pancreatitis. The first phase of pancreatitis is always the phase of organ failure and that acute inflammatory response. That usually goes about up to 7 days. And late phase is beyond 7 days where you get the other complications of local collections, necrosis, and infection. But these are not exclusive phases. Like this organ failure will be continuing in the beyond 7 days also, and it may be taking an up and down course when you get infected necrosis, and all those things. So it's just for arbitrary. You can say the first 7 days will be usually predominated by the organ failure and complications, whereas the second phase usually the issues will be related to the local collections and infection. Again, revised Atlanta, this already we have discussed. It is not like after 28 days it becomes walled off. It is actually a continuous process, and this is for defining that condition, and for the research purpose it is defined like those which are within 28 days, you call them as acute fluid collection. There is a caveat in it, I'll come to that point later on. And then those who have already formed a walling off on imaging, and those are, that usually happens beyond 4 weeks. They are called pseudocyst or walled off necrosis. It can be this pseudocyst and walled off necrosis, both can be either sterile or infected. Again, definitions, this necrosis can also be necrosis and pseudocyst. All these complications can be either pancreatic or peripancreatic, that is in the outside pancreas tissue. It can go anywhere from neck to the thigh. All these necrosis and collections can happen, and most of the cases it will be a combined. You will have some pancreatic necrosis as well as some peripancreatic necrosis. Again, this is important. This pancreatic acute pancreatitis management, the role of surgeon is very limited. You need a big team. It is a multidisciplinary care, and in the first phase, most important is critical care. Only if you have an excellent critical care and hemodynamic management, you will see this infective complications of pancreatitis. Otherwise, those who are likely to develop infective complications will die in the first phase itself. So you won't see these patients for managing the infection and all. So only if you have a good critical care unit, you will see the infected necrosis and other antecedent complications. Again, most of the time, these local complications are managed by either interventional radiologist or interventional gastroenterology. And this hepatobiliary surgeon has a limited role in some of the situations, which I'll explain. And then again, infectious disease specialist, because it will be a continuous process and you will have various types of infection, gram-negative bacteremias and fungimias. You will require a good infectious disease specialist with you to decide on the antibiotics, because it will not be like you give antibiotic and it is treated. It will be a continuous process. So choosing the antibiotic from the beginning itself will be when to start and when not to give. All those things are important. Then this critical care nursing and other nursing is extremely important. Nutrition, most of the time we will be trying to maintain them on enteral nutrition. Only if it is not possible, we go for parenteral nutrition. And then again, those who are having a prolonged morbidity and ICU stay and all, there will be you will require a very good rehabilitation team to get them back to life. So coming to the local complications, as we have mentioned, you can have acute necrotic collections and acute fluid collections, which can eventually evolve into walled-off necrosis or pseudosis. It can be sterile or infected. Then some of the other complications which will require our attention are the vascular complications like pseudoaneurysms or venous thrombosis, bowel communications and perforations. I will just go through these things shortly and I'll outline the management of all these complications, external fistulas and pancreatic or pleural fistulas, all those things. Types and locations, you can have pancreatic necrosis either in the peripancreas, as in the first picture. You can see this is mostly in the pancreas. Almost all pancreas is necrosed. Whereas in the second, next common site is the paracolic locations, that too mostly on the left paracolic. You can see the second picture, where is a large infected necrosis on the left paracolic. In the same picture, you can see this is the duodenum. The tube is actually an esophageal feeding tube. This is the next common site, that is the necrosed pancreatic head. You can develop a collection in the head or at the root of mesocolon. And the fourth site is the right paracolic and the on the right side. So these are the common site. Most of the time it will be on the pancreatic and left paracolic. Less frequently you see on the right side and the root of mesocolon, which are more difficult to access and more difficult to manage. Diagnosis of infected necrosis. This again we should know. Not all pancreatic necrosis patients on the 7th day, 10th day developing fever or infection. So there is basically these all came from the PANDER trial, that is a landmark trial, and they have given a very clear definition for the infected necrosis. That is, you have a definitive diagnosis of infection if you have a positive culture from a pancreatic fluid aspirated either by FNA or surgically aspirator, or the presence of large amount of extravisceral air on the CT scan. This air can be either due to infection or due to a bowel communication. If you see, MR sometimes help you to differentiate this. The MRI may show even before it is evident on the CT, you may see microbubbles on MRI. That may be a sign of early infection, especially those in the second phase, late second week and all. You are doubtful whether the inflammatory response going on, organ failure is persisting, whether it's infective or inflammatory. MRI may help in those situations. Again, there is another group of patients where you may not be able to demonstrate an infection clearly by a culture. So these are the patients like persistent sepsis or progressive clinical deterioration despite giving a good critical care. The patient is just deteriorating. The organ failure, like they had an organ failure in the first phase, which showed some improvement and then showing a deterioration again. These are the patients where we may make a presumptive diagnosis of infection based on the clinical deterioration. Then again, this is the same points which is enlisted. So indications of intervention in a pancreatic collection, pancreatic necrosis or pseudocyst is basically, it can be either a symptomatic sterile wound or symptomatic fluid collection, or presumptive or definitive diagnosis of infection. So the commonest indication being, especially in those with severe pancreatitis, continuing in the multidisciplinary ICU with organ failure, will be an infected necrosis, whereas those patients who have recovered from a moderately severe pancreatitis, went home and coming back, those patients usually the indication is, as in the last case, it will be a symptomatic collection, either causing a local compressive symptoms or that mass effect. So any patient with an asymptomatic sterile wound, irrespective of the sterile wound or pseudocyst, irrespective of its size or its location or its walling off, doesn't require treatment. It can be observed closely. If they develop symptom or if they develop any signs of infection, you can proceed with the intervention. This is again indications or intervention. In this first case, it is a clear diagnosis of infection from the air in the necrosis. Whereas in the second situation, it's a patient with a huge retrogastric collection. It can be either a fluid collection or necrosis, which is symptomatic because of the compression on the stomach and other local structures. Again, another point I wanted to highlight is in the acute, as the consequence of acute pancreatitis, you rarely get a clear, the pure pseudocyst. Almost always it will be a combination of fluid plus necrosis. So they are all, basically you can call them all as Waldorf necrosis. Making a diagnosis of pseudocyst, clear pseudocyst on an acute pancreatitis and its sequelae, it's a bit difficult. Always you have to look for the solid content in it. And CT may sometimes confuse you. It gives that both solid and that high density liquid will be almost same density. So you may not be able to differentiate it. In those situations, MR may help to differentiate how much solid content is there. There will be some amount of necrosis in all patients with those who are developing a pseudocyst or a Waldorf necrosis with from acute pancreatitis. That pure fluid pseudocyst we usually see in chronic pancreatitis complications. So regarding the management of this infected pancreatic necrosis, it was showing a multiple shifts from open necrosectomies to minimally invasive necrosectomies, then step-up approach. So it was always a changing concepts, and over the last 10 years, it has moved to a minimally invasive step-up approach. So there are two major approaches. There is a conventional open approach, which is a single stage or a staged approach, and minimally invasive step-up approach, which can include all the percutaneous, radiological, video-assisted, retroperitoneal approaches, endoscopic or laparoscopic. Basically, these two approaches differ from their this thing. Like open approaches, you are going a transperitoneal. Whereas in this minimally invasive step-up approach, it's always you are trying to contain the infection in the retroperitoneal plane. Timing of intervention, again, as residents were saying, it is like after 4 weeks or 6 weeks only you intervene. That is the general rule, and always we have to try to delay the intervention. There is ample evidence if you delay the intervention, the outcomes are better. You should not intervene on an acute necrotic collection just because the patient is having high running fever or some inflammatory markers are continue to be raised, or some of the organ failure which happened in the first phase is still persisting. That is not actually an indication. So usually we have to wait unless there are pressing indications like we have mentioned, a rapid clinical deterioration or clinical symptoms or infection. You should delay the intervention. But some cases it can be confusing. Sometimes the first episode of pain might have been mild and it may be ignored by the patient, and they may be coming with a Waldorf necrosis and a complication related organ failure currently. So that history you have to always ask. There's some hospitalizations or mild pain in the past which may help you to decide when a patient is requiring an earlier intervention. Same way, if the organ failure is not improving or if the modes is worsening in spite of giving good critical care, you may have to go for intervention in those patients. Going to the conventional approach, nowadays nobody does these approaches like debridement, open drainage and closed packing, necrosectomies and redressing and planned reoperations on every second day, third day for some time till you control the sepsis, and closed necrosectomies. Those series carried a mortality of 8 to 40%, and the main problem was here intervening transperitoneally, and those who have got a bowel communication spontaneously, or those who develop a communication or bowel injury from infection, it will become a transperitoneal leak and it is very difficult to manage. So the major concern was the morbidity in that era. So then the advantages of conventional, the proponents were saying it is a single stage, you can control the sepsis in a patient who is otherwise unstable. But this completeness is again debatable because most of the time the necrosis will be a continuous process. At a time when you are intervening, it may not be complete and you may still get necrosis evolving after that. Some of the disadvantages, it is you are going on a major procedure on a patient who is already on an organ support and a critical care support. So CIRS response may be exacerbated and many of them won't tolerate that. And then transperitoneal spread I have already mentioned, and more chance of hollow viscous reported in those series. Evolving necrosis, again complete control is not possible. So this was the landmark publication which came in 2010. That is a step-up approach versus open necrosectomy from, it's a Dutch trial, which has shown a minimally invasive step-up approach. Rather than going one step, you go step by step, put a tube, drain the infection, and it has shown a significant improvement in morbidity. Though the mortality was same in those patients in both groups, there was a significant improvement in morbidity related to the bowel injury and all. So it was the long-term pancreatic insufficiency and hernia were all those things, local complications and morbidity was more there. Again, minimally invasive approaches, that standard approach what we all follow is a percutaneous drainage of the collection, and then we go for an upsizing of drain, then we start flushing through the drains, and that is the first step. That is a percutaneous approach. Then you have an endoscopic approach which has come up in the last few years, where you go for an endoscopy, you put a lumen opposing or a large self-expanding metal stent, you get an access from stomach into the collections which are accessible from stomach, then go through that track, put a Ryle's tube across the stent, and you can start flushing the same way as a percutaneous approach, and then you can go for a direct endoscopic necrosectomy using this Domia basket and other these things. Laparoscopic, again transgastric, which residents previously we discussed either surgical or a transgastric cystogastrostomy. Percutaneous approaches I have mentioned, percutaneous catheters, upsizing, and then you go for flushing. Video assisted retroperitoneal, you can put a small incision in the retroperitoneum and then you can approach, and then open retroperitoneal approach, again a bigger incision in the retroperitoneum, but you will not be going transperitoneally, you access from outside. The percutaneous, the advantages, it's suitable for patients who are on organ failure, multiple wounds, you can approach, put multiple tubes, and then mostly retroperitoneal route, and you are not spilling the infection. The disadvantages are pancreatic fistula, it will invariably end up on a pancreatic fistula, longer hospital stay, and there are some financial concerns regarding that. This is the sinus tract necrosectomy. We use the urologist that percutaneous nephroscope for doing the necrosectomy. You go through the sinus tract, irrigate, and then take out the necrosis using the forceps, stone catching forceps. This is again a video assisted retroperitoneoscopy. You go on a sinus tract guided, you can put an incision and put your laparoscope and go through a small incision and take out necrosis. Then video assist, then you can have an open incision, bigger incision in the extraperitoneal lateral incision, and you can approach the collections in the paracolic location. Going to the endoscopic approaches, the advantage is you can either put a pigtail stents when you have mostly liquid as the content, but for those who have necrosis, you have to invariably go for a self-expanding lumen opposing stent, and then you will have to go for flushing and necrosectomies. This is the endoscopic approaches. Definitely endoscopic approach carries, it needs expertise, but it carries less chance of percutaneous fistulas. But it can be done only those who have an accessible those who have a collections which are accessible from stomach. Disadvantages of endoscopic, it can be done only in the favorable locations, but it needs, it can be done only in a well-walled off collections, and technical expertise and these equipments are required. These are some of the publications on endoscopic versus step-up. All have shown some advantage for endoscopic when both are possible. Going to the conclusion for practical approach, basically you have to look at the condition of patient. If you have a patient who is on multiple organ failure, you have an infected collection, definitely either percutaneous or endoscopic approach is better, depends on the location and available expertise. Whereas those who have got a symptomatic large collections, you can go for a laparoscopic approach or surgical approach. All these things are possible. Going shortly to the bowel communications, most of the time it can be a spontaneous rupture into bowel. Sometimes the collections resolved by spontaneous rupture, but most of the time it will land up, when you have a large amount of necrosis in it, it will land up on infection. And what we do nowadays is we just go for a contrast study to demonstrate a colonic communication or a gastric communication. Gastric and duodenal communication usually we manage by an distal to that we put a feeding tube and feed and control the peripancreatic sepsis by percutaneous approaches. Whereas if we have got a colonic communication, especially when patients developing a large amount of air in the collection rapidly, or those who are showing a rapid deterioration in the second phase, third phase, we always investigate for colonic communication and we go for a diversion, and then you go for the usual way of peripancreatic sepsis control by percutaneous approaches. So that is the way we managed bowel communications. Again, this is one patient who is showing a contrast leaking from the drain, from the duodenum. You can get these communications in all these areas. Vascular complications, again, arterial like pseudoaneurysms, which are managed by interventional radiologists. It's like GDS pseudoaneurysm in a patient with a pancreatic necrosis, which is already been drained and which is managed by a interventional radiologist by angioembolization. Venous thrombosis, they are very common complication, like 20 to 30% will get either SMV, splenic or portal vein thrombosis, and they are usually asymptomatic. Rarely cause venous ischemia of the bowel, which may need an early surgical intervention, and their prognosis is likely to be bad. Anticoagulation is the treatment for these asymptomatic ones, and delayed interventions are required, as our residents discussed, like for varices or hypersplenism. Again, pseudocyst, treat only if it is symptomatic. Either you can treat it endoscopically or laparoscopically. External pancreatic fistula, it is an inevitable complication of percutaneous approaches. Most of them resolve spontaneously. Disconnected ducts may need a transpapillary stenting or a surgical tractoenterostomies in rare resolving cases.
Shall we
Yeah.
wind up, Doctor?
Thank you. That is the last slide. Pancreaticopleural, again, we just drain and
Indeed, it's a very extensive presentation,
Topic, yeah.
rapid, but so cute. So, I have only two comments to add. One thing is, don't underestimate, of course, whenever we deal with the suspicion of internal strangulation in case of pancreatitis, internal hemorrhage pancreatitis.
Yeah.
There was a case where it was labeled as, because of time, limited time, I'm not going to the detail. Second thing is abstinence, about to prevent a
recurrence of pancreas. Yeah.
From your,
Very excellent presentation.
Thank you.
Very exhaustive, but
Yeah, it's a big topic
requires
actually.
more time.
one last question. From your practice, if you have I have a CT evidence of an infected necrosis with raised inflammatory markers and the patient has fever, is that an indication for an intervention or?
Yeah, if you have a large amount of air appearing suddenly, even if it is
Not
an
suddenly, from the kind of CT you showed initially.
yeah, that is that and all is actually their follow-up CTs on 3rd week, 4th week and all. Usually we try to delay the intervention, but if you have an air appearing like that in that CT, you have to intervene. There is no doubt. You have to investigate for a colonic communication also. When you get such large amount of air suddenly in a paracolic collection, we have often seen colonic communication, and we'll go for drainage and we'll go for a diversion also. If there is no colonic communication, go for drainage. First you go for percutaneous, then upsize. Then in another 3 to 4 days, we'll start flushing, multiple tubes and flushing, and then those who are not resolving go for a sinus tract necrosectomy. That's our approach now.
Any questions? Then we will wind up the session.
Thank you.
Thank you, sir. May I request Dr. Mohammed Salim to kindly hand over a certificate to Dr. Shabir Ali, please. Thank you, sirs. For our next case presentation and topic presentation, may I please invite onto the dais Dr. Srinivasan, Dr. P.K. Mohanan, Dr. Binny John, and Dr. Sri Kumar Pillai, please. Case presentation by Government Medical College, Kottayam, Dr. Adarsh S. Babu and Dr. Josna K. Jose.
Good afternoon to all. Myself, Josna K. Jose,
Adarsh S. Babu.
from Government Medical College, Kottayam, presenting a case of breast lump. My patient, 56-year-old lady, homemaker from Kottayam, presenting complaint, lump in the left breast for 1 year. Coming to the history of presenting complaint, she noticed a lump in the left breast while bathing. It was insidious in onset, gradually progressed from the size of a lemon to the current size over 1 year. It is not associated with pain. It is associated with nipple discharge for 2 months. The discharge is watery, not foul smelling, yellowish white in color, and minimal in quantity. There is no history of nipple retraction. There is no history of skin changes or ulceration over the swelling. There is no history of swellings in the axilla or neck. No history of trauma to the breast or fever. There is no history of loss of weight or appetite. And there is no history of backache, jaundice, breathlessness, or hemoptysis. Coming to the past history, she is a known diabetic for 3 years and is on insulin for the last 3 months. She is a known hypertensive and on medication. She has a history of CVA 5 years ago and she is on medication for that, and there is no residual neurological deficit. There is no history of previous surgeries, no history of hormone replacement therapy, there is no history of radiation exposure. Coming to the personal history, there is no history of smoking or alcohol consumption, normal bowel and bladder habits, and mixed diet. About menstrual history, he attained menarche at the age of 16 years. She is P1 L1. Age at the first childbirth was 24 years, and after which she breastfed for 1 year. Age at menopause 47 years. There is no history of malignancy in the family. Coming to the summary, 56-year-old female with non-comorbidities of type 2 DM hypertension and past history of CVA came with complaints of painless lump in the left breast for 1 year, associated with minimal serous nipple discharge for 2 months duration.
Examination. I have examined the patient with implied consent in a well-lit room with adequate exposure in the presence of a family attendant. Patient is conscious, cooperative, and oriented. Patient is obese and well-nourished. Height is 148 centimeter, weight is 59 kg, BMI of 30. ECOG is 0. Pulse rate 88 beats per minute in right radial artery, regular rhythm, normal volume and character. BP is 112 by 80 mm of Hg in right brachial artery in supine position. Respiratory rate is 12 per minute. SpO2 98%. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Inspection. Patient was first examined in the sitting position with the arms by the side of her body. Both breasts are equal in size. There was a swelling noticed in the left upper quadrant of size 3 into 2 centimeter. No ulceration over the breast. There is no dilated veins, dimpling or pudiorange appearance on the skin. Nipple is normal in position and symmetrical. No retraction of nipple. Nipple complex is normal. No active nipple discharge. No fullness in the axillary or supraclavicular region. On examining the patient with arms raised above the head, there is no pudiorange appearance or nipple retraction. On examining the patient while asking the patient to lean forward, the breast falls equally on both sides. On asking the patient to keep hands over the hip and contract and relax alternatively, there is no change in the fullness. Palpation. No local rise in temperature or tenderness. A 4 into 2 centimeter swelling is palpable in the upper outer quadrant with well-defined and irregular margins. Consistency is hard. Surface is smooth. Skin over the swelling can be pinched up. On asking the patient to press hands over the hip, no restriction in the mobility is seen. There are no palpable axillary or supraclavicular nodes. No nipple discharge noted. Percussion. On percussion over the sternum, there is no dullness. Opposite breast, axilla and supraclavicular fossa are normal. Other system, CVS, S1, S2 heard, no murmurs or added sound. Respiratory system, bilateral air entry equal and normal vesicular breath sounds heard. Abdomen soft, no palpable masses or hepatomegaly. Skull and spine normal. Summary, a 56-year-old female, type 2 DM, with type 2 DM, hypertension and past history of CVA, presented with the complaints of painless lump in the left breast for 1 year with minimal serous nipple discharge for 2 months. On examination, she was found to have a hard 402 centimeter swelling in the upper outer quadrant with no intrinsic mobility and no axillary or supraclavicular lymphadenopathy. Probable diagnosis, left carcinoma breast, staging T2N0, early breast carcinoma.
Yeah. I think from the history now, it's almost very clear that it is carcinoma of the breast, and I don't think you have a differential either. Do you have any differential diagnosis? Not really. What are the history-wise and finding-wise? What are the things which would substantiate your diagnosis history-wise?
56-year-old female
Okay.
with a painless lump, painless progressive lump. And coming from examination,
But there is no recent onset, no recent increase in size, nothing like
Nothing
that.
like that.
Yeah, about discharge, you said, which discharge is significant?
bloody discharge,
Bloody discharge? is-
spontaneous, serous, sanguineous,
Yeah,
less-
serous, spontaneous, serous,
single
watery, bilateral discharge, or unilateral, whichever way, unilateral discharge. Bloody discharge is more common where?
intraductal papilloma.
Duct papilloma. So don't say bloody discharge for malignancy. It is not normally a bloody discharge. One thing. And I think in the summary, you should definitely say that it is a post-menopausal lady, because that is very important. Okay. So what is the WHO definition of menopause.
Absence of
Absence of menopause for 1 year.
Is it 1 year or 2 years?
1 year.
1 year.
Continuous absence.
Continuous.
Continuous.
You had mentioned something, retraction of nipple. One history, what is important history asked when you asked retraction of the nipple?
the recent onset retraction.
Whatever is the age, you should say retraction. And as I have said, you said 56 year, here only you have to put the female postmenopausal. Whatever the age is, postmenopausal. So people put it in thyroid or stomach. But here breast is very, very important. Retraction of nipple and skin changes you have put. No skin changes. That will suffice. Why do you want to add ulcer and other thing? That is one. You added an extra point which you don't write. The history of repeated abortion was there. Is it important or not?
That will decrease the cycle, number of cycle.
You didn't mention this. Then you said pure orange is there.
No,
Not there. Okay. Percussion over the sternum or parasternal?
parasternal, second, third, and fourth interval.
You had mentioned percussion of this time. Have you done a PV or a PR examination? Is it complete, your examination?
We should have been done a PR.
It should be not done or it should be done. That's all. Otherwise, your presentation was good.
The initial complaint of the patient was serous discharge. Was it? You mentioned in the complaints. Serous discharge associated with the lump, which you noticed. Is it not? Is it not the complaint which is?
Lump.
Will you give any significance to that complaint? Or serous discharge?
Spontaneous serous sanguineous discharge.
Your final diagnosis, you put it as a carcinoma of the breast.
In Andy also it can.
Anti. Possibility of underlying anti.
Single spontaneous serous discharge is highly suggestive of malignancy.
Single, it's a unilateral problem. That is important. For her, it is a unilateral. She committed, I think it's a unilateral. Significant.
You made a diagnosis of carcinoma breast. What are the findings in favor of carcinoma breast?
Postmenopausal female with a painless progressive lump. Then from the examination, there is a well-defined irregular swelling, hard in consistency.
Hard.
Hard in
Right.
consistency with fixed to breast tissue.
Any differential diagnosis with this finding?
Traumatic fat necrosis.
Traumatic fat necrosis. So will you consider that
There is no history of trauma.
trauma? So no known history of trauma. In the general examination, you mentioned no edema of the pedal edema. No pedal edema. Any other part you will look for edema?
Upper limb.
Okay, you mentioned that. No. Okay, upper limb edema you can mention in all breast cancers, depending on which side it is. Okay. Good presentation.
See, along with supraclavicular, you have to always say infraclavicular also. Okay, infraclavicular fullness.
Fullness.
infraclavicular. You have to mention that specifically. Okay. Yeah. So if it's
So
okay.
diagnosis acceptable and fine. All right.
Yeah. So what will you do? How will you go about?
We will go with triple assessment. After history and clinical examination, we will do bilateral breast mammography and a core biopsy.
Why a mammogram?
Age.
Why would you do a mammogram?
Age of the patient is 56.
No. Why would you do a mammogram?
To look for any multicentric nodes and
What's the
No, no,
aim
but-
of doing a mammogram?
First of all, when an investigation is asked, you should say why you will do. Second, you should say what you will see. Third, you should say what are the, like BIRADS and scores. Okay, so why will you do a mammogram?
Dr. Soymar, I think they mentioned that they will do bilateral mammogram. By any situation which you do a unilateral mammogram. Why is
If
this?
the other breast, if they have post mastectomy or we
That is a
all.
different situation. In a regular practice, we should not write for a bilateral mammogram. It's implied that whenever you take a mammogram, it should be violent as soon as breast is there, right? Other one is post-mastectomy status, isn't it?
I'll just modify sir's question. Already you know that this could be carcinoma of breast and you can do a true cut biopsy and confirm diagnosis. Why do you want mammogram in that situation? That is the question you have to answer.
To look for any other impalpable lumps,
Okay.
to look for axilla,
Multicentricity,
Multicentric lesions.
Lesions.
Okay.
any impalpable small lesions present or not. Diffuse, diffuse calcification,
microcalcifications.
looking for axillary lymph nodes.
So does it actually going to change your the way you are going to treat the problem?
It is an early breast carcinoma now. If it is a multicentric disease, we cannot do a
Okay,
BCS.
That's why you are going for a investigation of mammogram, right? It's going to change the management.
Signs of malignancy in a mammogram, quickly say.
Architectural distortion, microcalcification, taller than wider lesion, speculated margins, then axilla, there is loss of shape to round shape,
Yeah.
then loss of atelier.
Taller than wider, is it actually applicable in breast?
Not really. Clusters of pleomorphic calcification, architectural distortion, speculation, and all those things. Okay. So you have done a mammogram. Mammogram says that there is a lesion in the upper outer quadrant, no multicentricity, nipple areola is normal. That is your mammogram. So multicentricity, multifocality, the definition you should know. I hope you know that. Okay. So what next will you do?
Core biopsy. Core biopsy.
Core biopsy. Why a core biopsy? Why not an FNAC? Usual exam question.
We cannot differentiate in situ and the invasive component by FNAC, and also we have to do an IHC for
What do you look for in an IHC?
ERPR status, HER2 new status, and KI67 index.
Okay. What is Ki67?
Proliferation index. Proliferation index.
It is a proliferation antigen, which tells you the
Number of mitochondria.
and these four things help you in classifying breast according what
Luminal,
molecular class.
Okay, you have completed something now. At the end of this, what altogether, what do you call it? Up to this point, assessment, what you have done?
Triple assessment.
Triple assessment. Very good. Sir.
What is the size of the true cut biopsy? How do you do a true cut biopsy? I've done a true cut biopsy.
Yes.
What is the size of the needle?
14 or 16 gauge needle.
How do you do it?
After obtaining the consent, under aseptic precaution, give a local anesthetic, fix the tumor, and put a skin incision and a 45-degree angle. We generally pass 3 passes.
What all will you look for in a biopsy? True cut biopsy is advantages over FNAC, isn't it? In what way?
In situ.
In situ and invasive carcinoma can be differentiated.
There's no negative. What are you going to do for it? It's N0, isn't it? So you would leave it like that, or you would lose another thing?
Yes. Single lymph node biopsy can be done.
See, in pathology, what else do you look for? What is the most commonest type of breast carcinoma?
Non-specific type. Invasive duct carcinoma, non-specific type.
Infiltrating duct carcinoma, NOS, not otherwise specified, or not NST. And grade, what are the 2 types of grade? One is histological grade, 2 is nuclear grade. So histological grade, I hope you know the system in which you know the name?
Modified
Bloom-Richardson.
Not Bloom-Richardson. You know the variables which are checked?
Tubular
No,
formation, nuclear.
Pleomorphism.
Okay. Yeah.
So right now you have a patient with breast cancer. That is a diagnosis. And you termed as early breast cancer. What are you going to do for her? The lesion is situated size?
4 into 3 centimeters in the
4
upper outer
into?
quadrant. 3 centimeter.
3 centimeters, 4 into 3 centimeters in the upper outer quadrant. Axilla is negative. Isn't it? No palpable lymph nodes. were there. On the mammogram, was there any lymph nodes detected on ultrasound?
No detector.
No lymph nodes in that. What are you going to do for this?
Breast conservative therapy.
Postmenopausal?
Breast conservative therapy can be
Can you
advised.
straight away go for treatment at this point? What you have done, you arrived at a diagnosis. What is next?
We will discuss the patient
The option.
options, available option.
You have to go for staging investigations, right? You have to go for more
Staging.
investigations. So what all staging investigation you want to do?
Since it is an early breast cancer,
Okay.
LFT and chest X-ray may suffice the metastatic work.
Chest X-ray and LFT.
LFT.
But I would say you have to do an ultrasound abdomen also. All right.
Pathology has come as infiltrating duct carcinoma, NOS, ER strongly positive, PR strongly positive, HER2 negative, Ki67 10%. What next will you do? Mammogram shows a single lesion, no multicentricity.
We can go for breast conservative therapy.
What is breast conservation surgery?
Wide local excision with 1 centimeter margin. And in therapy, we will address the axilla plus followed by radiotherapy.
What would you do for the axilla? What is the current consensus for the axilla?
SLNB, sentinel lymph node biopsy.
SLB. How is it done?
We'll inject a 2 to 4 ml methylene blue dye peritumorally or periareal intradermally.
No,
Then-
actually, it is 0.2 ml in each quadrant, not total, not 2. 4 ml will stain the axilla very badly blue. Okay, so don't use 4 ml. 0.1, maximum 0.2 ml. Intradermally, subcutaneously, intratumorally, peritumorally. Okay, yes, then you look for what? Then after injecting, what do you do?
Massage the
When would you inject this?
Before wash.
It is done
30
on
minutes.
table,
On table.
approximately 15 minutes prior to your surgery, isn't it? Yeah. Then you massage, then you look for what?
blue stained lymph nodes in the axilla with a separate incision in the axilla.
With a separate incision, you take a biopsy, right? And SLNB comes as negative, what will you do? SLNB comes as positive, what will you do?
SLNB negative, no need for any procedure. SLNB positive, we will do an axillary lymph node dissection.
Now axillary lymph node dissection, what level will you do?
If the lymph nodes are present in the level 1 and level 2,
No,
we'll
we said lymph nodes are clinically not palpable. Ultrasound also does not show lymph nodes, significant lymph nodes, but SLNB is positive. So what level you'll do?
level 1 and 2.
Level 1 and 2. Can you tell me what are the landmarks for your axillary dissection?
Superiorly axillary vein,
Okay.
inferiorly angular vein,
Okay.
and all fatty tissue between thoracodorsal and long thoracic.
Chest wall, chest wall, thoracodorsal. This is level 2. Suppose it is level 3. What is the ligament there?
Halsted ligament.
Very good, very good.
So you have done a sentinel node. How many nodes are usually captured in a sentinel node biopsy?
All blue nodes and a palpable node if present. 3 is suffice.
3 to 4 lymph nodes are generally captured in a sentinel node biopsy. Okay, so before sentinel node, you should have done an ultrasound, right? Because clinical palpation is only 50% sensitive to detect lymph node, which are significant. So what are the ultrasound features of a affected lymph node, metastatic
of
lymph
fat.
node?
Loss of shape. It will be a round shape, loss of fatty
Right.
hyaline,
What is the normal shape?
oval or kidney shape,
Bean shape, right? Then
loss of fatty hilum,
loss of central fatty hilum. So the two significant findings on ultrasound, right?
What are the contraindications for BCS?
multicentric disease,
This patient. Yes, multicentricity.
large
Loud.
Tumor breast ratio is high, multicentricity. If already we have done a BCS and the margin positivity, BRCA positive patient, BRCA positive patient.
Central quadrant. Poorly differentiated tumors.
contraindication for radiotherapy,
Which disease is the contraindication?
collagen vascular disease,
Collagen vascular. In collagen vascular diseases,
SLE.
SLE, not rheumatoid arthritis. Rheumatoid arthritis is not a contraindication. Okay. Yeah. Then tell us something about oncoplasty. What are the types of oncoplasty?
There are 2 types of oncoplasty.
Level one and
Level 1 and level 2. Level 1 is volume displacement. Level 2 is volume replacement, where we take an extra mammary tissue for maintaining the aesthetic look. And in level 1, we'll do a local regional rearrangement, dermoglandular displacement, like that. Examples are superior.
What are the 3 factors on which you decide whether it is level 1 or level 2?
So less than 20%
We'll go for
level 1.
level 1. Second factor,
Site,
site of the tumor. Third factor, ACR density. A is fatty, D is dense, B is heterogeneously, and 3 is, read that up. Okay, ACR density. These are the 3 variables on which you decide whether it is oncoplasty type 1 or type 2.
This patient, you are shown the photograph in between. And will you suggest an oncoplasty procedure for this patient? 56-year-old, right? Postmenopausal. Will you suggest a oncoplasty?
It's a large breast with 4 into 3 centimeter.
Pardon?
4 into 3 centimeter
Size tumor.
So,
Upper outer quadrant.
so there is
So
no.
for an oncoplasty, it is a favorable site. It's going to give a good result. What is the undesirable thing happening in the patient after oncoplasty? This patient, in particular, this patient.
the other
patient
breast
is
may need
on-
augmentations.
Patient requires
Other breast may need augmentation surgery.
asymmetry resulting from a major resections is going to be undesirable one for the patient. Or what will you suggest then?
Other breast may require an augmentation procedure.
Reduction to
Reduction.
Treatment wise? Okay. Adjuvant.
Post-operative follow-up for this patient.
For the first 2
Adjuvant
years.
treatment.
Adjunct.
You have done a you have done a BCS, which comprises of 3 things you said. Then how do you follow up the patient for adjuvant therapy?
For systemic therapy. We will for
See, pathology, it has come as, it is a 4 into 3 centimeters tumor. Margins are clear. You have done an axillary lymph node dissection. Totally, you have harvested 12 nodes, out of which 4 have come as positive. And they are ER, PR positive, HER2 negative, Ki67 10%. Tell what is the adjuvant.
we will go for systemic therapy, which include adjuvant chemotherapy, hormonal therapy, and we also go for radiation since the more than 4 nodes are positive.
No, BCS always radiation has to be given. Okay, please make that very clear. Always radiation has to be given. And how, do you know what is the dose of radiation? 40 grays in 15 fractions and 16 grays in 8 fractions as a boost.
Tumor boost.
Okay, 40 grays in 15, 15, and 16 grays in 8 fractions. And what is the chemotherapy that you use normally and how many cycles?
8 cycles, 4 cycles of anthracycline waste and 4 cycles of taxane waste.
Taxol based. So what is the side effect of Taxol?
Cardiotoxicity.
And what is the hormonal treatment that you would give?
Yes, since it is a postmenopausal female, aromatase inhibitors are used. For that.
What is the normal aromatase inhibitor that you use?
Letrozole and estradiol.
Letrozole, isn't it? Dose of letrozole?
10.
2.5 milligram once daily. Complication of letrozole? Osteoporosis. So you always add what?
Calcium and
Calcium. How long you give?
for lower.
Minimum?
5 years.
5 years. Some people give for 10 years.
According to what sir has said, any other treatment is required. He said HER2 positive, sir.
HER2
negative. Okay, fine. Right. Okay. Suppose
Positive,
I
what do you
change
do?
it to HER2 positive.
Trastuzumab can be given. Trastuzumab.
So how many injections? How frequently?
1 year for 1 year duration, once in 3 weeks.
3 weeks. Maximum 18 injections can be usually given. Right. How does trastuzumab help?
It acts on the S1 and decreases the proliferation of these cells.
Arrest the cell cycle.
Okay.
Well done. Good. Excellent. Keep.
Thank you, ladies. May I please invite Dr. Mir Chishti next, Assistant Professor, GMC Patnamthitta.
Good afternoon, one and all. Can we move to the presentation? Yes, okay. So let me thank the organizers for having given the opportunity to discuss this very important practical topic, and also for the excellent hospitality shown by the organizers. So you all know that breast cancer is a major public health hazard because it still outnumbers all other anatomic sites by a large margin. Thanks to the previous case discussion, we have had something like an elaborate discussion on what I was about to discuss here. Thanks to the chairpersons for that. So let me change track here. We will discuss something else. I will discuss something about Hollywood. See. Okay, so this lady you see here is Elizabeth Bloomer. She was a small-time actress, a singer and dancer. She subsequently went on to marry US Senator Gerald Ford, who later became the president of the USA. A couple of weeks into his presidency, First Lady Betty, she was called Betty Ford was diagnosed with a breast cancer. There was a large amount of discussion whether they should go public or not. And Betty Ford decided to go public with her malignancy. And she, mind you, this happened in 1974. She underwent a radical mastectomy. This photo was released to the public a couple of days after her mastectomy. And all statistics say that following this revelation by the First Lady, a large number of ladies across the US came forward with self-diagnosed breast lumps. This phenomenon came to be called as Betty bump, and the sharp spike in the number of diagnosed cases came to be called as the Betty Ford blip. Okay, so how do you manage a patient who is coming to you with a breast cancer? There are umpteen number of guidelines ranging from the ubiquitously quoted NCCN to St. Gallen, ESMO, ASCO. Even we have our own guidelines, that is the National Cancer Grid Guidelines, just published by the Tata Memorial. But I would recommend you to read up on this, the ESMO guidelines, because it gives the guidelines quite clearly and fluidly. Workup we have already discussed, triple assessment. One thing you need to keep in mind, always do a core biopsy and send the specimen for assessment of ER, PR, HER2/neu, and proliferation index. Okay. Other tests are not routinely recommended in an early breast cancer unless the patient has specific symptoms. Mammography, you look for speculated lesions or microcalcifications. Histology, ductal cancer invasive outnumbers all other types by a large margin. Corneal biopsy, apart from the routinely available test, nowadays you can even go for a vacuum assisted biopsy, which gives you a bigger chunk of tissue. Bloom-Richardson, based on tubule formation, nuclear size or mitotic count, and you have the differentiation. This is very important. You have to know the molecular classification of breast cancer if you intend to treat the patient, because all current guidelines depend on molecular classification. 4 types classically: luminal A, luminal B, then HER2/neu positive, and basal, which is nothing but the other name for triple negative breast cancer. But if you look at the current edition of Bailey, it gives one more type, that is the Claudin-Low type. But none of the guidelines have come up with specifically tailored management for Claudin-Low. But since this is there in the textbook, it might be good to know. So luminal A is usually hormone receptor positive, HER2/neu negative, and proliferation index is low. Luminal B is usually again hormone positive. HER2/neu is usually negative, but there is a subtype with HER2/neu positivity. Ki67 is high in luminal B. Basal type is a triple negative. HER2/neu enriched, also called as the HER2/neu positive. If you look at the prognosis, luminal A has got best prognosis. Luminal B comes with intermediate prognosis. HER2/neu and basal are the ones with the worst prognosis. Apart from these, you can also do genetic footprints like the MammaPrint, Oncotype DX, somewhat expensive, not commonly available, but sometimes that can also guide you to decide on the adjuvant therapy. I'm not going into the staging. It is simple like what T1 less than 2, T2 2 to 5, T3 beyond 5, T4 of course A for A for the chest wall, B for skin, C combined, D inflammatory. Nothing has changed. CN1 ipsilateral mobile axillary lymph nodes. N2 is either fixed axillary lymph nodes or internal mammary in the absence of axillary. N3 can be infraclavicular or internal mammary with axillary or supraclavicular. Pathologically, it is a number of lymph nodes which matters. N1 is 1 to 3 and N2 is 4 to 9, N3 beyond 10. M stage even has got a subtype, whether the diagnosis of metastasis is based on clinical or pathological confirmation. Stage grouping, the left half, that is stages 0, 1 and 2 are the ones which come under early breast cancer. So let's go to our second heroine. That is Anne Frances Robbins, who took on the stage name of Nancy. She married one-time actor and later Senator Ronald Reagan, subsequently became Nancy Reagan. Nancy Reagan was also unfortunately diagnosed with breast cancer. This happened in 1987. This photograph was again given to the press following her mastectomy. And this created a huge uproar in the medical fraternity because this is the time when Umberto Veronese and Fisher had already established the clinical equipoise of wide local excision. In spite of that, Nancy decided to go for a modified radical mastectomy. And it is said that following her choice, many ladies who would have otherwise gone for a wide local excision decided to go for a mastectomy. Let's go back to our treatment. So we have many heroes in the treatment of breast cancer, radiotherapy, hormonotherapy, but the superstar is still surgery. Surgery is the primary modality of treating breast cancer. How do you treat? You have an early breast cancer. It is a tumor which is less than 2 centimeter. It is amenable for breast conservation. Go for breast conservation. If the patient doesn't wish for breast conservation, you can go for mastectomy. However, if the patient has got any adverse factors, inclusive of a triple negative histology, patient is HER2 positive, a large size tumor, or axilla is positive, you have to go for what was previously called as neoadjuvant therapy, is nowadays called as systemic induction therapy or a primary systemic therapy. Do that and try to get a response. If you're going for wide local excision, it's nothing but clearance with 1 centimeter 3-dimensional margin all around. I'm not going into volume replacement. Displacement was beautifully described just a couple of minutes before. What about the margins? Bailey says absence of inking on the tumor by the pathologist is sufficient. But the aim is to get 1 millimeter of margin. If the pathologist tells you there is no tumor on the inked borders, you are happy. There is no problem. The incision is tailored depending upon where is the location of the primary and what sort of oncoplasty you are going to do. You can either go for the simple type, that is a volume displacement, or much more complicated volume replacement with lots of flaps, like you can go for a tram flap or an intercostal artery based flap, thoracodorsal flap, etc. When do you go for a mastectomy? If the tumor has got adverse factors, that is, if the tumor to breast ratio is not good, or if the surgeon is unable to achieve negative margins in spite of multiple resections. And nowadays there is even a facility for attempting skin or nipple sparing mastectomy if the margin between the lump with sufficient normal tissue and the skin and or the nipple is acceptable. So the incision for mastectomy has evolved much from the classical Halstadian radical mastectomy to the currently acceptable Stewart's transverse incision or an obliquely paced or ORR, O's incision. The classical teaching again for mastectomy was to raise the flaps till the clavicle superiorly and till the upper fibers of the abdominal muscles. The current Bailey says the upper border is till the second rib superiorly. The lower border is till the inframammary crease. Medial and lateral borders have not changed. It stays still the same. When do you go for a neoadjuvant systemic therapy or a pre-operative systemic therapy? If you want to downsize the tumor to try for a breast conservation, or it's a HER2 positive tumor, or it's a triple negative breast cancer, or in premenopausal women because they are likely to have aggressive tumors, or patients with lymph node metastasis. And if you are planning a BCS after a neoadjuvant systemic therapy, the tumor site should be marked either with magnetic markers like a MagSeed or with implantable wires, but always mark the tumor. And you assess the response based on the change in the size of the tumor. Sometimes it can completely disappear, or it can give a partial response in the form of more than 30% reduction, or stable disease when it reduces in size but without reducing more than 30%, or it could be progressive when the size increases beyond 20%. Sentinel lymph node we have discussed just a few minutes before. So look at the sentinel lymph node based on the fluorescent light or the visual color. When do not go for sentinel lymph node biopsy? Inflammatory breast cancer, T4 disease, or patients with history of previous breast or chest irradiation or surgery. These are the absolute contraindications. ALND, you need to clear all contents of axilla while protecting the axillary vein, thoracodorsal nerves and vessels, pectoral nerves, long thoracic nerves, and if and when possible, intercostobrachial nerves should also be preserved. Level 3 clearance done only when 1 or 2 are enlarged. You have done a primary systemic therapy. Now, what about the axilla? If the patient was clinically not negative, after your PST, you can do SLNB. Supposing the patient was clinically not positive, and now after your PST has turned clinically not negative, you can still carry out sentinel lymph node biopsy in selected number of cases. And all otherwise indications, you have to go for axillary lymph node dissection. Adjuvant therapy is decided on many factors ranging from the patient's age to the molecular status. So you have mainly 4 arms. It can be hormonotherapy, radiotherapy, chemotherapy, or anti-HER2 therapy. Radiotherapy has got a local effect. You give it after all cases of BCS, and after mastectomy, if the tumor is large, involvement of chest or skin, if there is lymphovascular invasion, higher grade, or any node positive. And the previously, if you look at the recommendations, more than 4 nodes positive was considered as the indication for radiation. Now it has changed to even if the patient is positive for 1 to 3 lymph nodes, and if the patient has got any aggressive risk factor, it is better to go for radiation. It is given in both NCCN guidelines as well as the ESMO guidelines. Usually you give the classical radiation as 45 to 50 gray over 25 fractions, or what is preferred in most centers nowadays is to give 40 to 42 gray in 15 fractions, that is a hyperfractionation. Okay. Chemotherapy has again changed the survival of patients right from the classical CMF regimen to the current regimens which contain basically anthracyclines and taxanes. Indications: all invasive carcinomas bigger than 1 centimeter, and all invasive cancers more than 0.5 if they have any adverse factor like a lymphovascular invasion, higher grade, HER2 positivity, or triple negative and not positive. It is usually given as between 4 to 8 cycles, mostly as anthracycline based regimens. And currently the risk of recurrence score, what we discussed earlier, the genetic assays that can be used to calculate ROR scores, or even there are online free predictors like this. You can input all your patient details there and you can know whether the patient will benefit from chemo or not. Hormonotherapy, tamoxifen 5 years for all low risk, 10 years for high risk. And for aromatase inhibitors, it is 5 to 7 years. Bisphosphonates are indicated if the patient has any bone loss. High-risk patients, ovarian suppression by ablation or LHRH agonist. Of course, tamoxifen with the increased rate of uterine cancers. Aromatase inhibitors with the increased rate of bone density loss. Anti-HER2 therapy, trastuzumab, 1 year. One problem is this is again cardiotoxic, so do not combine this with anthracycline-based therapy. If the patient doesn't respond well, you can change over to a newer type of therapy called TDM1, in which you combine trastuzumab with a chemotherapeutic agent that is emtansine. So this is a sort of the flowchart for doing this. Okay. So based on the molecular therapy, luminal A tumors, low risk, hormonotherapy is sufficient. Luminal A hormonotherapy is sufficient for low risk. Luminal B, all need anthracycline or taxane-based chemotherapy. HER2 new positive, chemotherapy along with trastuzumab. Triple negative, chemotherapy, sometimes higher grade chemotherapy is required. So early breast cancer, this is the flowchart. Follow up for the first 2 years, you follow up the patient every 3-4 months and do an annual bilateral or contralateral mammography as the case may be. Following the first 2 years, for the next 3 years, you do a 6 to 8 monthly checkup of the patient and then annually thereafter. So coming back to the story of Hollywood actresses, this is Christina Applegate, who was the star of many rom-coms in the 90s. She was diagnosed with a primary breast cancer along with a BRCA mutation at the age of 36 and had to undergo a double mastectomy. So what do we do? So what do we have here? Just to summarize, any early breast cancer, if and when possible, go for breast conservation. And depending on the patient's wishes, you can go for mastectomy. Any aggressive factors, you have to do a pre-operative systemic therapy and try for a breast conservation. So is all hope lost? Not at all. In all breast cancers, if you can diagnose at the proper time and manage well, patient can have a near normal life. Both our heroines, that is Betty Ford and Nancy Reagan, lived well into their 90s and even outlived their spouses. So there is always hope if you are able to do the correct management. Thank you.
That was really wonderful. The lighter being the first ladies, first ladies of the US, probably put the whole the breast cancer into sort of a turmoil. All of them seem to be getting Ford and Reagan. No?
Yes.
Wonderful, Christy. You have explained it extremely well.
Thank you, sir.
Yeah.
Excellent, sir.
Thank you.
I think it is open to discussion.
Then any questions? If there is no more questions, thank you, Mir, for the excellent presentation. We'll wind up the session.
Thank you, sir. Thank you, everyone.
Please stay.
May I request Dr. Benny John to kindly hand over a certificate to our esteemed speaker. May I request all the other panelists also kindly join, sir. We have the master lectures next. May I invite the chairpersons for the session, please? Dr. E.V. Gopi, Dr. Ashok Nainan Oman, Dr. Rajan Kumar, and Dr. Dinesh Babu, please. First lecture by Dr. Ajit Prasad, Associate Professor, GMC Trivandrum. I hand over the proceedings to our esteemed chairpersons. Over to you, sir.
See, often I have always wondered what a good class or a talk would be. And over the years, taking classes, I've realized that at the end of the class, at the start of the class, somebody will begin to sleep. At the end of the class, everybody will be sleeping. And so sweet will be the talk that I have been used to that. and I bring that sort of expertise and greetings from my institution. So my topic actually was rapid response, expert care, and saving lives in blunt trauma abdomen. But I had doubts. So I called up my mentor, Almighty God, and then asked him, see, I don't know, I'm not an expert. True, you're not an expert, he replied. And then he asked me, are you a rapid responder? No. Then I said, but God, I can save lives. So by saving lives, I'm an expert. And I'm also a rapid responder. And hearing that, God has never appeared again. He has simply gone offline. And here I am. Saving lives. And that saving lives, that phrase carries within it rapid response and expert care. Now, this incident happened in a medical college hospital. A 13-year-old was brought in unconscious. At the very sight of unconsciousness, the duty persons ordered a CT brain. And off she went. And while CT was being done, she collapsed, died. Postmortem examination revealed nothing in the brain but a shattered spleen. So such incidents should not happen again anywhere in the world, not to speak of our institutions, not to speak of our state. So my endeavor is to help all residents here, since this is a CME meant for postgraduate trainees. My endeavor is to make them aware of how to deal with a blunt trauma abdomen case. Now, this is the fundamental. And I should go through this fundamental just because we have to save lives. The first is a new introduction, that is control of exsanguinating hemorrhage. Often, this word exsanguinating is often forgotten. The meaning of exsanguination, sanguine means blood. Exsanguination means blood is lost totally from the body, so much so that the patient dies. It is that sort of hemorrhage. It's not simple hemorrhage. Blood trickling down a small scalp wound is not. It should not be dealt with in the first step. It is exsanguinating hemorrhage. Followed by airway. We all know airway is the pathway through which oxygen goes in, just like rail running on railways. And then breathing is the chest movements, and circulation is simply ensuring that whatever blood is remaining is which is packed with oxygen is shunted off or pumped off to distal parts of the body, so that a life body remains for us to tackle the injuries. And then disability and exposure are the things which follows in a primary survey. Now, one thing I want to assert is that loss of consciousness is simply not the sole propriety of head injuries. Somebody having lost blood can lose consciousness. That orientation is often missing among postgraduate residents. And that is why I emphasize again and again, loss of consciousness need not alone be due to head injury. It can be due to blood loss. In a trauma patient, we will have to suspect. So, which are the sites from which blood loss can occur, by which a patient can die? One is chest, two is extremity, especially thigh, femur fracture. Three is pelvis, and four, abdominal cavity, including the retroperitoneum and external wounds. External wounds, profound blood loss might have happened outside even before the patient is being transported in. We'll all have to keep that in mind. So these are the 5 sites which we will have to suspect whenever there is a disastrous bleed. When a suspecting bleed, these are the 5 sites. Mind you, this does not contain the cranial cavity. Even before the cranial cavity can produce that much of a bleeding, the patient might have gone up. The effect of even small bleeding in the brain is simply because it is compressing the brain and producing all sorts of nuisances. It's not because of loss of blood. Now, there was a TV show in which, somewhere in North India, some TV people were asking medical students this simple question: when will somebody die? I mean, after blood loss, after how much blood loss? The first question was actually how much blood is there in a human body. And mind you, no medical student could answer that question. It's very unfortunate. And this is how it goes. 15 to 20% of loss means patient starts to develop tachycardia. The extremities become cold because body shuts the peripheries to save the life of the patient. All blood is diverted to the vital organs. And then oxygen saturation drops 15 to 20%. And then 30 to 40%, the BP will also fall. There will be pallor, there will be tachycardia, the tachypnea. And then 50% is not sustainable. So 2.5 liters gone means that person is not going to survive. Now, how can one bring the hemodynamics back? We all know starting fluids and all, but the current concept is blood resuscitation. And we have to start it within 10 minutes. And one thing is that we have to keep the BP, the systolic BP below 90, so much so to reduce the chances of further bleeding. The BP should be maintained at 90 systolic. And pelvic binder should be applied in all hemodynamically unstable patients. That is one thing, one simple thing which can save lives. This awareness was not there before. A pelvic binder in a hemodynamically unstable patient. And one thing that is slowly coming up is tranexamic acid, 1 gram IV, which is given in 10 minutes in the initial 3 hours, and then followed by an 8 hours infusion, or 1 gram in 8 hours infusion. Now, this is a pelvic binder. A very, very simple thing. And the only thing that should be taken note of is the place where it should be applied. It should be centered over the greater trochanter. When the binder's center should be the greater trochanter. A piece of sheet which is readily available in any hospital is much, much better than a custom-made pelvic binder, which is the second figure. Any of these signs in an abdomen, think of visceral injury. In the right hypochondrium, it is the liver. In the left hypochondrium, it is the spleen. In the lumbar area, it's the kidney. So any abrasion over the abdomen, any contusion over the abdomen, any laceration of the abdomen, think of something missing inside. Now, this is a seatbelt sign. And FAST has revolutionized things. In almost every case, we are now used to get FAST. Just keep in mind, some reports come as mentioning only fluid. Don't think it is ascitic fluid, it is blood. And one more thing is that FAST will not give any idea regarding solid organ injury. So these two things should be kept in mind before assessing the results of FAST. And FAST can give fluids, and fluids means blood. Blood inside the abdomen cavity means visceral injury. And one more thing, FAST will not detect fluid in the retroperitoneum. So what are the investigations? Several lives have been lost without this recognition. most ideal investigation in the blunt trauma abdomen is CT scan. And whom to take a CT scan? Only in a stable patient. Never send an unstable patient to CT scan. And if you cannot rule out bleeding in the abdomen, ruling out bleeding in the abdomen means chest is normal or your chest tube is not draining any blood. The extremities are normal. You applied a pelvic binder and no significant external wounds are there. The only place that can have blood is inside the abdominal cavity. And the patient is unstable. It's not responding to your resuscitation. Mind you, the word resuscitation is a holy name, bringing back to life. We cannot just bring back somebody to life, but the noble way that we do things. And such is the nobility that the act that we are doing has been given the name resuscitation. So even after resuscitation, the patient is remaining unstable. The only place that the patient can be sent is the operation theater for a laparotomy. Whatever it is, without any investigations, straight laparotomy. Unstable patient, you are not able to stabilize, laparotomy. Unstable patient, laparotomy. A stable patient, CT scan. We'll come to the specific injuries in brief. How can one manage a splenic injury? Previously, when we were students, splenectomy was the only answer. But science has evolved and splenic salvage with, see what sort of techniques we have, radiofrequency ablation, argon, mesh wrapping, suture repair, partial splenectomy, splenography. So these are newer techniques by which we can save the spleen, not only the life. And these are questions which are often raised by residents. How can a person be managed non-operatively? So the person has to be in an ICU for 1 to 3 days. His or her hemoglobin has to be monitored. PCV has to be monitored 8th hourly. And one common question is, when can that person be immobilized? The immobilization is a must for 2 days because that can disturb the clots, and hence mobilization is done after 3 days, after 2 days. And if it is a grade 5, due to lack of time, I just can't explain the grades, but still, if it is 5th grade, then 3 consecutive samples of hemoglobin should not show significant changes before mobilization. And then next question is, when can oral feeds be started? Well. When bowels start to function, we can assume that things within the abdominal cavity are slowly settling towards a normalcy. And then we can start oral feeds. And then the upcoming thing, the life-saving thing is angioembolization. Liver injuries, well, non-operative management is the norm. In ICU for 1 to 3 days, again hemoglobin PCV, but one more additional thing is coagulation profile has to be checked daily, because liver is the thing that takes care of our coagulation things. And mobilization after 2 days, oral feeds again, and angioembolization. And how can we do an operative approach? We operated on an unstable patient, we found a liver injury, damage control approach is the ideal approach. There are radical approaches, but they are deferred to a second look operation. First, damage control. And how can it be done? One, you can compress the thing, that is push. Second is pack, and Pringle's maneuver are the maneuvers. But packing on the top surface and beneath the surface, and the liver get compressed in between, close and come out, save the liver, save the life. The second look, after 24 to 48 hours, you can take out the packs. Mesenteric and bowel injury, CT is the gold standard. It depends on what part of the bowel and the mesentery is damaged. Repair or ligation, bleeders can be ligated and the thing can be resected. Pelvic and urethral injuries, the pelvic binders are the norm for an unstable patient. And operative fixation can be done if things are not getting stabilized. The perineal hematoma is one thing which often residents miss. They simply don't know where a perineal hematoma occurs. Lift up the scrotum, look beneath, palpate. Any induration is an indication of a perineal hematoma. This is an extensive one, but lift up the scrotum and it's beneath that. Perineal hematoma. Often I ask students where a perineal hematoma, they have no idea. They only know perineal hematoma, urethral injury, perineal hematoma, urethral injury. And blood at the external meatus is a sign of urethral injury. Retroperitoneal hematoma is mostly conservative management. And this one, and the last one, how to manage a pregnant abdomen. See, 1.5 liters of blood lost from the mother means it's fetal death. And the basic concept is that treat the mother, don't bother the fetus. You treat the mother, the fetus will also be treated. And diaphragmatic injuries, it's a delayed recognition, a repair. And thank you, the organizing committee for indulging me.
Ajit Prasad, excellent presentations. As you mentioned one touching story, every day we have such as touching stories. And in Calicut also, one patient was sent for CT without any IV lines. Patient found that outside the CT room. So whenever patient shock, you should not send the patient for CT unless resuscitated. That's your from your talk. And this topic is open for discussion. Everybody has some comment about the trauma because every surgeon evolved after a course of trauma in their first 3 years in their casualty experience.
One thing is, see, in case of a trauma, patient coming to a casualty, naturally you have to think of these possibilities actually. You have to think of chest injury, you have to think of abdominal injury, you have to think of long bone injury. Then only you send the patient to CT or other investigations like. Chest injury you can detect by just doing a compression test actually. If there is blood sound is reduced on one side, actually you can just put a needle and do a needle thoracostomy. If abdomen there is a contusion naturally, you can think of abdominal injury. And another thing is in case of hemoperitoneum, the peritonitis will appear only later actually. It takes about 3 to 4 hours to appear as peritonitis actually. But the bowel injury naturally that will present within 1 hour actually. So immediately they will present with the peritonitis. So in case of bleeding into the peritoneal cavity naturally, you just put a needle. You can detect it. If there is a hemoperitoneum, there is no need of CT actually. You can directly take the patient to OT and do the laparotomy. So clinical suspicion is very, very important in case of trauma patients.
Thank you. Thank you, Dr. Ajit, for that nice presentation. You stressed on the fact that clinical examination is very important. Because nowadays the trend is to send them straight for the CT after the initial cursory examination. We also had a recent example of a patient came with trauma to the body trauma and he had a hemothorax. X-ray was taken in the casualty, but the X-ray was not seen. And he was directly, because there was transient loss of consciousness, he was sent for a CT. The patient collapsed in the CT scan room and there was no doctor with the patient. It was only the patient's bystander. So these sort of things do happen fairly regularly in every institute. So I think you stressed on the fact that there should be a good clinical examination, and even the FAST can be extended to visualize the pleural cavity as well for a hemothorax. That can be very easily done because even X-ray in the supine position will not show a hemothorax, may not be picked up. And similarly, importance of pelvic fractures, pelvic binder is absolutely important. And damage control surgery, again, very, very important because sometimes in an urge to save the spleen, we tend to spend a lot of time, lose a lot of time for that sort of a surgery. Yes. So we shouldn't take a fancy for such surgeries. We should do the bare minimum that is necessary in that first episode and then try to save the life of the patient. Thank you.
One point I want to mention, the diaphragmatic injuries. Unless suspected, nobody will detect these diaphragmatic injuries. Always suspect blunt injury, there is diaphragmatic unless proved otherwise. There is a one word for the pages. Always suspect diaphragmatic injury in blunt injury unless proved otherwise. So you can diagnose most of them by the only CT. Unless you suspect, you won't take the CT.
So the slide, retroperitoneum shown at the conservative management. It's one. retroperitoneal hematoma, here in the slide, it is written as conservative management. With retroperitoneal zone 1, we always.
I did not get you, sir.
So,
Retroperitoneal hematoma, you mention conservative management.
Sir.
That's one.
See, retroperitoneal hematoma, I meant retroperitoneal hematoma, you just don't go and disturb that particular hematoma because already the retroperitoneum is containing the hematoma. But if the patient is unstable, we will have to intervene. But lack of time, I could not explore too much details into this.
There's an avulsion injury of the hyoid of the kidney. You should not disturb the retroperitoneal hematoma. Is any comments, audience? As there's no more cases, we'll wind up session. Thank you, Dr. Ajit.
Thank you, sir.
May I request Dr. E.V. Gopi, sir, to kindly hand over a certificate to Dr. Ajit Prasad, please. May I request all the others to join in, please, all the dignitaries on the stage. Thank you. I'd like to invite Dr. Firoz, Professor, Department of Pathology, MES, Perindalmanda, to kindly deliver the next address. Next master lecture by Dr. Firoz, please.
A very good evening to all. Let me thank the organizers, Dr. Jose, Dr. Siddiq, for including me in this wonderful PG training program of the surgery's PGs. Now, solitary nodule thyroid is always a dilemma for a surgeon, for the simple reason that you got to take a decision on what to do. Active surveillance, lobectomy, upfront total thyroidectomy, on a nodule which you are not sure what is inside. You got a few parameters to make an assessment of whether it is benign or malignant. Now, this assessment is now keeping on increasing. New modalities are coming, and there is quite a decent assessment now before you take a decision. Two things happened last year. WHO came out with a new classification, and then it included the molecular studies also on the assessment of a solitary nodule thyroid. Bethesda reporting of thyroid cytology also came out with a recent edition, where again the approach is much better, and again the molecular test is given a focus. Basically, you've got 4 ways of assessing: clinical examination, ultrasound, you can do an FNAC, and then you can add molecular studies to make a decision on the management strategies. Clinically, I think basically 2 things mainly: fixation of the mass on the cervical viscera, vocal cord paralysis on the ipsilateral side, and you can do TSH, radioactive iodine, to make an assessment. Ultrasound, you got risk stratification systems, which basically standardizes the report and also provide a guidance for FNAC. TIRADS is one of such risk stratification system, where points are given to ultrasound features. Then all these points are taken together on each nodule, and then a score is given, TIRADS 1 to 5. The more solid the tumor is, more points. More hypoechoic, more points. Taller than wider nodule, more points. Extrathyroidal extension, calcification, more points. Then you finalize and come to a score. If it's TIRADS 1 benign, nothing has to be done. Even TIRADS 2, very minimal risk. The risk of malignancy, as you can see, is minimal. TIRADS 3, low risk. Risk of malignancy is 4.8. 4 is intermediate risk and 5 is high risk. And then the guidance is, the recommendation is only Tirades 3, 4, and 5, you go for FNAC based on the size of the nodule. Tirades 3 is unlikely to be malignancy, but then you find a few cases which are malignant, if at all, they are follicular carcinomas or a follicular variant of papillary carcinoma. So the challenge for the cytopathologist would be to identify the follicular carcinoma or a papillary carcinoma in Tirades 3. Tirades 5 has got a very high risk of malignancy, and very often it turns out to be malignant. But then the challenge for the pathologist again would be to confirm the malignancy or say that this is not malignant, let us avoid unnecessary surgery. That is what the pathologists have got to look at it. Management strategy based on Tirades, benign, nothing to be done, no immediate thing. You do the ultrasound again after 1 to 2 years. And then after 3-5 years, unless the volume increases by more than 50%, volume of the nodule, then you got to do a ultrasound again and repeat an FNAC. But if the USG is Tirade 4 or 5, and then you get a report, cytology report, which is indeterminate, which means it is AUS, follicular neoplasm, or suspicious for malignancy, then you have to consider a surgery. Now, what is this indeterminate cytology? When you get such reports, that takes us to the Bethesda reporting system of cytology. It is a uniformed, tired reporting system. We got 6 categories in that. The first category is non-diagnostic, which means you're not getting any material to make a diagnosis. You need at least 6 groups of follicular cells of 10 each to give a possible diagnosis. Otherwise, it is not diagnostic. The reason for non-diagnostic aspirates, technique is one, but then the nature of the tumor itself, it is very cystic. You can't expect much material to come. In the technique, you have to accept that thyroid is a very vascular organ and it contains a lot of colloid also. So you put in a needle and give vacuum, you can expect a little more of blood to enter the needle. That is why you got a procedure like fine needle non-aspiration cytology, which is very well done in a thyroid nodule. Usual FNAC, you prick a needle, 23 gauge, syringe, you aspirate, go different directions, aspirate, and hope for the best. In non-aspiration cytology, there is no syringe, no holder, nothing. Just the needle is introduced, taken into different directions. The material will enter the needle by the capillary action. Then you pull out the needle and then apply a syringe and express the material onto the slide. This non-aspiration cytology in many studies have shown that it is much, much better than the usual classical FNAC. The diagnostically superior material is more than double than an FNAC, and the unsuitable is less than half. Approach would be, if it is non-diagnostic, try and repeat that. And if you are repeating it, better use it with an ultrasound. Ultrasound guided aspirations would give much better result. And even better result if you introduce the ROSE, which is the rapid on-site evaluation of the slide, where the pathologist goes to the radiology department, he sits with the radiologist, and when the slide is taken out, aspiration, he does a rapid staining of the slide just to see if there is material or not. If there is a material, you stop the procedure, send the slides to the pathology department and do the processing to the reporting. If there is no material, the patient is still there, the radiologist is there, and then you can repeat it then and there. And make sure, again, ROSE, see if the material is there, you go ahead. Ultrasound guided would be much better. 2 successive non-diagnostic, then probably you have to think of a surgery. Second category, Bethesda, benign. 2/3 or more, 70 to 75% of the SNTs that you're getting are going to be benign. And this is the clinical use of the cytology, so that you pick up benign nodules and avoid unnecessary surgery. These are the benign ones, nodular colloid goiter, lymphocytic thyroiditis, granulomatous thyroiditis, and then the approaches, benign cytology, no further immediate management. But the follow-up would decide based on the ultrasound finding, based on the Tirade. Benign FNA, Tirades 5, You got to repeat the ultrasound within 12 months and repeat the FNA. Benign cytology, Tiraj 4, repeat between 1 and 2 years. Benign cytology, Tiraj 3, more than 2 years, you don't have to worry. Third category is atypia of undetermined signal. This is a very tricky one, a very dicey kind of diagnosis where you have something more than benign in cytology, but not really a follicular neoplasm or even suspicious of malignancy. Here, it is due to some nuclear atypia in the follicular cells, or you get oncocytic cells, you get a lot of atypical lymphoid cells, or even a solitary psammoma body without any cells. These are kind of tricky situations where you're not sure what it is. It is not benign, slightly more, but you cannot put it in any category. This has to be the last resort. You don't dump everything in the AUS category, category 3, and get away with it. The pathologist is supposed to report only less than 10% should be of category 3. And then I looked at our material here in MES, it was well below 10%. The category 3 was only 7.5%. And then I looked at a small number of AUS which underwent surgery just to see what is happening in the AUS. 1/3 of them were malignant. But then remember, 2/3 were benign. So it is a very close call. And for that, what more can you do to better your reports on AUS? The answer is molecular studies. In the AUS, now the Bethesda recommends, and the WHO also recommends, molecular study on the cytology smear, where you have AUS. And if the molecular is high risk, you go for surgery. If the molecular is also low risk, you can have an active surveillance. Fourth group is diagnostic. Category 4 in Bethesda is follicular neoplasm. You're sure that it is a follicular neoplasm, adenoma or carcinoma, minimally invasive carcinoma. So that is sure. The papillary is ruled out in category 4. And the cytology will be very clear. Risk of malignancy of being a minimally invasive carcinoma is about 50%. Here, the standard practice of Bethesda category 4 is lobectomy, and which is considered a sufficient mode of treatment. But here again, in category 4, you can finalize your surgery process by doing a molecular study. If the molecular is high risk, molecular profile in category 4 is high risk, you can take it as a minimally invasive carcinoma, go for upfront total thyroidectomy. If the molecular profile is low risk, consider it as a follicular adenoma, just do a lobectomy. Fifth category, suspicious for malignancy. This is something, the pathologist is sure that it is not a benign one. But then all classical findings of a malignant tumor is not there. Now, when I say it is category 5, we are not dealing with follicular adenoma or follicular carcinoma. It is the other carcinomas, papillary, medullary, anaplastic, etc. But not a definitive evidence of carcinoma. So what do you do that? Because of these findings. The approach here in category 5 is ancillary studies. Medullary can be ruled out by doing an IHC on the slide, synaptophysin or calcitonin. Lymphoma can be ruled out by doing a flow cytometry, the atypical lymphoid cells. If it is epithelial ones, then you can again go for molecular studies. Where, if it is a high risk molecular profile, go for upfront total thyroidectomy. Low risk, diagnostic lobectomy is all that is needed. Category 6, of course, is malignant. The pathologist is sure that it is malignant, other than follicular carcinoma, papillary, medullary, high-grade follicular, anaplastic, etc. The diagnosis is certain. So you don't need any molecular studies or other things like that. But then, the differentiated high-grade thyroid carcinomas, the treatment is slightly aggressive. You can go in for total thyroidectomy and lymph node dissection. And that takes us to what is this differentiated high grade. WHO last year brought out a new classification. They have got benign tumors and malignant tumors. In between, you've got a low risk neoplasm also. In the malignant again, between well differentiated and anaplastic, you have got this differentiated high grade thyroid carcinoma and poorly differentiated thyroid carcinoma, where the surgery again would be total thyroidectomy with lymph node dissection. Lastly now, what are these molecular studies? Both the WHO and Bethesda now wants us to do molecular on the cytology smear. Where do you do it? For benign, no. You're sure it is benign, you got a management. For malignant category 6, again no, because you're sure it is malignant, you can go ahead. It is the 3, 4 and 5. AUS, follicular neoplasm and suspicious for malignancy that you really do the molecular studies. The decision is between active surveillance or surgery. In the molecular, just remember that there are 3 categories only. One is RAS and RAS-like mutation, which usually goes with follicular neoplasm. They are of low risk. So molecular profile low risk is RAS and RAS-like mutation. We have RAS, P10 and DICER, a few of them. BRAF and BRAF-like. BRAF 600E, V600E and BRAF-like mutations, intermediate risk. It goes with the papillary carcinoma. So BRAF and BRAF-like mutations, intermediate papillary. You've got a third category, which is TP53, TERT promoter. High-grade carcinomas. These are high risk. It goes with anaplastic. It goes with poorly differentiated thyroid or differentiated high-grade thyroid carcinoma. So aggressive management. So these are the 3 classes you have. WHO says that BRAF-like or RAS-like, it is well-differentiated carcinomas only. TERT promoter or TP53, they are high-grade tumors. So, and in even that, RAS-like is follicular, BRAF-like is PTC. So, 3 molecular profiles. Benign, low risk, you just have to do a active surveillance. Intermediate, like BRAF-like, you go for lobectomy, that will be sufficient. High risk, TP53 and TERT promoter, go for total thyroidectomy, lymph node resection. So basically, that is how it goes. You got different ways of doing molecular. The last 2, 7-gene test panel and NGS is now gaining a lot of popularity. And so concluding now, the management strategy is based on clinical, of course. Then you have ultrasound, TIRADS 1 to 5. You got FNAC, Bethesda, category 1 to 6. And now you have a molecular profile, low risk, intermediate, and high risk. So you got pretty much things to ponder upon. And then you can take a decision of whether it is active surveillance, whether you want to go in for lobectomy or a upfront total thyroidectomy. Thank you very much.
Thank you, Professor, for your excellent presentation and more enlightening about the molecular investigation. I have one doubt. You are the instead of FNAC, you can't do all the case undergo this negative aspiration, negative pressure aspiration.
Non-aspiration cytology.
Non-aspiration.
Yeah. In thyroid, generally we try the non-aspiration, where you only put in the needle, go to different directions, and then take out the needle. You express it on the slide, you get a lot of material without blood or colloid. If you aspirate that, it's a very vascular organ. So a lot of blood comes out, and your material goes into the piston of the syringe, and nothing comes out on the slide. So non-aspiration is better.
No, any doubt? You can ask questions.
So what about the frozen section in follicular neoplasm?
Frozen sections, generally, they don't recommend. See, for the reason, in follicular neoplasm, there is a Bethesda category 4 that sir is talking about. It can be a follicular adenoma or a minimally invasive carcinoma. Now, this minimally invasive carcinoma is the cytologically or morphologically adenoma carcinoma looks the same. The diagnosis is based on the capsular invasion or vascular invasion, for which, even if you give us a total thyroidectomy, what we do is we cut and take the entire capsule in 3 or 4 sections to see or rule out a capsular or a vascular invasion. Now, frozen, we cannot afford to take that many sections. So, you may take 1 or 2 sections here or there. You may not see a vascular invasion or a capsular. So, generally, frozen is not recommended in.
So, the capsular and vascular invasion usually on the periphery, actually.
It is in the capsule, yeah, periphery.
Suppose we are taking the FNAC from the periphery of the swelling.
Yeah.
Can we yield the diagnosis?
No, capsular and in the FNAC, you're only looking at the cells. You're not looking at the architecture or invasion. So, cells morphology in adenoma and carcinoma, there is hardly any difference. If it is a minimally invasive. Anaplastic is different. It looks very pleomorphic, but follicular neoplasm, hardly any difference.
Thank you. That was a nice presentation.
Yeah, thank you.
How frequently are you doing this molecular profiling?
Molecular profiling?
Yeah.
Well, in our institution, we don't have the molecular profiling. It is being sent somewhere if it is necessary. Yeah.
And how much does it cost? How much?
NGS will cost quite a bit, but the 7 panel, maybe 5,000, 6,000, I think they give. Yeah.
You differentiate the Hurther cell neoplasm is a
Yeah.
molecular investigation required.
Yeah.
Hurther cell neoplasm.
Yeah. Now, the Hurther cell adenoma versus carcinoma, it is again the high risk and low risk. You can do the, yeah. Yes, please.
So I just want to ask you, so
Yeah.
you said that you would do ROSE on-site exam.
Yes, right.
So what is the staining that you do when you do a ROSE?
We do a rapid HND or a methylene blue. The idea is only to see whether there are cells or not. We are not going to give a diagnosis on that. If the cells are there, the same slide is taken and we do a papinecolon stain or gene
Can you
therapy.
do that staining after
We
doing the-
can do. We can destain that and the same slide we can use for the PAP or other things.
Thank you very much, sir.
Yeah.
Wonderful talk. As usual, we are very lucky to have such a wonderful pathology department with us.
Thank you.
And it's a great pleasure.
Yeah.
So, sir, as you said very correctly, many a times we have to have difficulties with the patient relatives coming and telling that FNA reports are not good. And this is a big suggestion that sir has given, this ROSE test. And we can ensure that in our first go itself, we get adequate specimen to have. Sir, regarding that,
Yeah.
just a doubt about
Yes.
it. There is also that term which you mentioned in between, NIFTP.
Yes. No.
What regarding that,
yeah.
in terms of the difference between the usual Bethesda with NIFTP.
Yeah, NIFTP or non-invasive follicular tumor with papillary-like nucleus is a category that comes in between the benign and malignant. The WHO has now put it as a low malignant potential category. It basically means that the nucleus has got features of papillary in many areas. It is not a classical papillary carcinoma. You don't see any papillae, neither you see any vascular or capsular invasion. It is basically an encapsulated follicular variant papillary carcinoma, not classical, but something less than that. So they didn't put it in the malignant category, they put it in the intermediate category. That is NIFTP.
Okay, sir. Thank you. Thank you.
Yeah.
As there are no more questions, we'll wind up the session. Thank you.
Thank you.
May I request Dr. Ashok Naik Noman to kindly hand over his certificate to Dr. Firoz, please? Request all the other panelists also to kindly join in.
I also request the chairpersons to kindly hand over a token of appreciation to those faculty who conducted the hands-on session, ultrasound abdomen and venous. I invite Dr. Rajan Janardhanan sir on stage.
Respected teachers, my colleagues, my dear friends, and postgraduate students. First of all, greetings from Sri Gokulam Medical College, Venyaramuda, Trivandrum. And I am here to make an announcement regarding a CME that we are going to conduct on 29th of this month, October, in our campus. And this time, we have chosen a single theme. We have chosen thyroid as a single theme for our CME. It's an institutional CME. And we have eminent teachers like Professor Dayananda Babu sir, Marisa Pandya sir, and big names in Kerala of medical colleges coming to enlighten us with the various aspects of thyroid diseases. I think it would be a very useful session for the postgraduate students, and I request and invite all of you to join this CME. Thank you. Thank you very much.
Postgraduates taking part in the ward rounds, this is for you. Postgraduates taking part in the ward rounds on 1st of October will be given an opportunity to see the cases after the quiz program. PGs are requested to contact the arrangement desks and announcement desk for the quiz. Now, we'll have the quiz competition coming up next.
Before we move on to the quiz session, I request Chairman, ASI Kerala Chapter, Dr. MP Srijayan sir, to kindly hand over a token of appreciation to the faculty who conducted the hands-on session, USG Abdomen and Venous Doppler today. Sir. Dr. Binny John. Dr. Tom. Thank you, sir. I invite Dr. Vijay Paul, HOD, Department of General Surgery, MOSC Medical College, to the stage.
Respected senior faculty, colleagues, and dear postgraduate students, in continuation of the previous announcement, there's another announcement. This is about the ASI Kerala chapter peripheral meet, which is the next major event on the ASI calendar. This will be on February 10th and 11th, which is the second Saturday and Sunday, 2024, to be held at Kolanjeri, which is near Ernakulam, for those of you who don't know. It's my pleasure to cordially invite all of you to attend this program, which we are still in the process of formulating. We are definitely planning a good academic feast, and I sincerely request all of you to kindly attend this program. Thank you.
We have the quiz competition coming up next, the much awaited quiz competition. All the students, PGs who are participating in this, who have been selected for this, are kindly requested to go to the preview desk to mark your attendance. Please go to the preview desk. All participants of the quiz competition requested to kindly go to the preview desk. Thank you.
Good evening, everyone, and welcome to the grand finale of Science Year 2023. So, after a tiring day of hardcore academics, we have come to the fun and entertainment part, of course, with a lot of learning involved. So, before we start off with the finale, I'd like to announce the results of the faculty quiz, which was also conducted on the Tackle platform. We had an enthusiastic response from faculty throughout the state with some great scores. To announce the results and to hand over the gifts to the faculty, I invite respected Dayananda Babu sir. Sir, please. Yeah. So, we'll start off with the third prize. So the third prize goes to Dr. Mir Chisti from Pathanamthitta, from Medical College Pathanamthitta. Congrats, sir. Now for the second prize goes to Dr. Arjun from MES. Congrats, Dr. Arjun. And now for the coveted first prize, it goes to Dr. Alfie Kavalakad from Jubilee Mission. I think sir is not here, so I'd like to invite the HOD from Jubilee Mission. Sir, could you please come on this stage? Ashok, Dr. Ashok? Okay. Any postgraduates from Jubilee Mission? Yeah, please. So she'll be receiving the award on behalf of Dr. Alfie. Please give a big round of applause for the first prize. Now, this is the first prize. Okay. So now it was a closely fought battle, and we have selected 6 teams. I'll be calling out their names. The teams are requested to please assemble near the audiovisual area. Team GMC Trivandrum, Dr. Sandhya and Dr. Shilpa. Dr. Sandhya and Dr. Shilpa. Team GMC Kozhikode, Dr. Yadu Krishna and Dr. Suraj. Team GMC Kottayam, Dr. Amit Monsi and Dr. Sophia Mohan. Team GMC Alappuzha, Dr. Akshay and Dr. Rahul. Team Lourdes Hospital, Dr. Jinsha and Dr. Safwan. Dr. Jinsha and Dr. Safwan. And Team MOSC Medical College Kolancheri, Dr. Nandita and Dr. Rishikesh. Okay. Now you've got are all the teams here? All 6 teams? Okay. Now you will be picking 2 sets of lots. Each team, 1 member can pick a lot. Asif, lot. One will be your team name, team number, and the other will be the set of questions which you will have for round 4. Okay. So pick 1 from each lot. Team GMC Trivandrum. Okay. You can hand it over to me. The set you can keep it with you. Just the team name you give it to me. So team GMC Trivandrum will be team C. So this will be team A, B and C. That will be your seat in the middle. This is team GMC Kozhikode. So you are team F right at the end there. Can keep the other chit with you. You are team GMC Kottayam. You are team D. So just next to team C. Your team from team GMC Alappuzha will be team E.
Okay. Okay, team B, you are from Luth Hospital. Please take your seat. And lastly, you will be team A. You are from MOSC Medical College, Kolanjeri, right? You are team A. Here's your seat. Please keep the set numbers with you. We'll come to that during round 4. So, without much ado, I'll introduce myself. I'm Dr. Shafiq, I'm a surgical oncologist from MBR Cancer Center. So, I'll start off with the rules of Scientia 2023. There will be 5 rounds in total. And I'd advise all the teams to look carefully at each slide, especially in rounds 1 to 3. Few slides will have a dollar mark that denotes a bonus question. Means after the direct question in that slide is asked, there will be a bonus question which will be answered as per the buzzer. So can you all please check whether your buzzer is working one by one. Team F, please press your buzzer. Okay. E, team E. Okay. Team D. Team C. Team B. Okay. Team A. Okay. So the bonus question will be a buzzer. It will be open to all. All of you can apply the, go for the buzzer. 20 seconds will be there to answer each question in most of the rounds, except during the rapid fire, where you will have 8 questions to be answered in 40 seconds. Okay. Marks vary for each round. I will be explaining it as and when the occasion arises. And there are negative markings only for round 4 and 5. The negative mark will be half of what you would get for a right answer. Now there is an interesting aspect of Scientia 2023 is the involvement of faculty. So you will have faculty as lifelines. Use your lifelines judiciously. You would be able to use the lifelines only in round 1 and round 5. The other rule to remember is, if a question carries 20 marks direct, if you choose to use your lifeline and the faculty gets it correct, you will get only 10 marks. Whereas if you answer correctly, you will get 20. And likewise, if the answer becomes wrong, half of that will be lost. And the other thing to remember, other thing I want to ask is, have all the teams got their lifelines? Team A, can you identify your lifeline? Dr. Najib. Can I see Dr. Najib? Yeah, okay, there. So, Team B, your lifeline? Okay, Santosh sir. Team C, your lifeline? Dr. Ajit? Yeah. Team D, your lifeline? Doctor? Dr. Bibin? Yeah. Team E, your lifeline? Who? Sajiv Kumar sir. Okay, sir. And Team F, your lifeline? Dr. Sona. Okay. Sure. So the lifelines are settled. So mostly there will be no passing of questions. If you notice, all teams have got a notepad in front of you. Okay. And during the initial rounds, you will be able, as a direct question is asked to one team. Suppose I am asking a direct question to team A, all the other teams can write down the answer. Okay. And before the team A answers the question, all your chits will be collected at the end of 20 seconds. If team A gets it wrong, whoever has answered it correctly will get the full marks. So there is no issue of passing, you be in proximity or away from a place. So it is to eliminate that bias. Okay, is that clear? The bonus question is not to be written. As I mentioned earlier, it's only for buzzer. And please make sure you identify your team name on the chit paper so that we can identify which team has answered, right? I need some volunteers here. അല്ല പെട്ടെന്ന് കളക്ട് ചെയ്യുന്നത് 2-3 പേര് മതി. So can the volunteers be ready? Yes, sir. വേണമെന്നില്ല, 2-3 പേര് കളക്ട് ചെയ്യുന്നത്. Yeah. So and as in any quiz, there can be more than one right answers, but I assure all of you that I have personally verified and re-verified the veracity of most of these questions myself. So this rule is the most binding rule in this quiz. There will be no discussions or controversies on any of the answers. If at all, we can settle that after the quiz. Okay, so the quiz master's decision is final and binding. So shall we start? Teams, are you ready? Okay. Yeah, Venda. You can write your team name, team A, B, C, D, whatever it is on the sheet paper. The first question will be to team A. Scorers, are you ready? Time? Okay. So here comes the first question to team A. This round is on personalities. Okay. So you have to just identify this personality. I'll give you a clue. He is known as the father of angiogenesis research. And there is a dollar sign there. So this is going to be followed by a bonus question. Team A, time. Okay, your time's up. Please collect the papers. Pettannu. So both team C and D have attempted. The answer is they have not answered it correctly. So the question is open to the audience. Anybody in the audience? The father of angiogenesis research. Nobody? This is Judah Folkman. Okay, he is known as the father of angiogenesis research. Now here comes your bonus question on your buzzers. Okay, the bonus question is, based on the research that Folkman did on angiogenesis, there is a particular type of treatment for cancer which came into vogue. It actually involves giving low dose of chemotherapy so that it targets the endothelial cells in the blood vessels supplying the tumor. So that is a whole concept. You have to tell me what is the name of that treatment modality. This is open for buzzer. 10 seconds. Okay, team E. Yes. What's your answer? For 10 marks. Yes, please. Mic on, alle? Yeah, correct answer. It's metronomic chemotherapy. It's actually written there. Okay, metronomic has different senses. So this first slide is a pointer to all of you. Please don't look here and there. Look carefully on the slide. The answer may be hiding on the slide. Okay, so this is called metronomic chemotherapy. 10 points to team E. So good answering. So now we'll go on to team B's question. This is the story of a renegade resident. This is a book written on his life, the man who touched his own heart. You have to identify who is the man. Identify that famous German scientist, doctor. Timer. You can use your lifeline if you want. For 20 marks. Okay, time up. It's nobody attempts. Okay, so audience, open to audience. Who is this? Yes, exactly, Werner Forssmann. So this is Werner Forssmann. So now you can see there is a dollar sign there. So there is a bonus question coming up. All is not lost yet. Hands on your buzzers. The bonus question is, what is the other claim to fame of Werner Grossman in the history of medicine? It's very simple. What is his claim to fame? One is this book is written on him. Yes, Team F. Answer? No, that's not the answer I want. That's all there in the book. Claim to fame in the history of medicine. So -5 there for Team F. The answer, audience? Sorry? Nobel Prize. He won the Nobel Prize for this discovery. Actually, it is this X-ray, is probably unique in the history of medicine, that this X-ray fetched him the Nobel Prize in 1956. So he had actually catheterized on himself using a urethral catheter successfully. Later he became a urologist. So he was awarded the Nobel Prize in 1956. So next question to Team C. So this is the story of the immortal woman. You have to identify her for 20 marks. Time starts now. Yes? Give me her name. I don't want any short forms. Give me her name.
Can we use our lifeline?
You can use your lifeline. I think sir. Okay. Okay. If the faculty doesn't answer, there is no negative. The faculty can choose not to answer.
Hela.
You want to attempt?
I mean, the cells are called HeLa cells.
Fine. But that's not the answer I want. What is her name? Okay. Collect the cheats from the other teams. Nobody? Okay. So, audience? Henrietta Lacks. Correct answer. Is there some prize for the audience as well? Something? No. Okay, that should come later. Anyway, so it's Henrietta Lacks. Again, there is a dollar sign here. So still time to score. The question that follows is, Henrietta Lacks had a malignancy from which the cancer cells were cultured in the lab for first time and they became immortal. They continue to live on. I want you to tell me what malignancy she had. Okay, Team C.
C is cervical cancer.
Okay, I'll give it to you. 10 marks to Team C. Okay. So now to Team D, your direct question. This person is called the Hippocrates of naval medicine. All the other teams can write down your answers if you know. Just identify the person. The clue is on the frontispiece of the book that he wrote. If you want, I will give you one more clue. In post-Renaissance era, this is widely hailed as the first instance of a randomized control, of a randomized control trial that he did. Time up. So let me check the answers. Team F and which is the other team? C. You have to write your name correctly, okay? Team A. So all the other teams have got it correct. Anybody from the audience wants to identify who this is? James Lane, correct answer. So Team A, Team C and Team F gets 20 marks. Okay? So the bonus question, time still there for Team D. Hands on your buzzers. I mentioned that this was probably the post-Renaissance era earliest randomized control trial. I want you to tell me what was the most modern, in the modern era, 20th century, what was the first instance of a published randomized control trial done on? At least give me the name of the disease on which it was done. This happened in 1946. It was published in 1946 by the Medical Research Council of UK. Just tell me the name of the disease or the drug which was used in that trial. The first ever randomized control trial in 20th century. Time? Nobody wants to attempt? Yeah. Okay, time up. Audience? Which disease? Which remained a scourge for centuries? No. Something which is even there now. We are struggling with it. Tuberculosis. Streptomycin in tuberculosis. That was the first randomized control trial in 1946 which was published. Okay. So we go on to team E. This is your question on the Prince of Physicians. You can use all the clues that are given there. There is no $sign, no bonus question. For 20 marks, identify the name of this person. He lived from 980 to 1037 AD. He was a Persian polymath, often called as the Persian Galen. His most famous work is the Al-Qanun fi al-Tib, and he believed that anatomy is the cornerstone of medicine. William Osler had this to say about him, that he was the author of the most famous medical textbook ever written. Okay, time up. I'll accept the English name or the Arabic name. Only one answer. Team C. Audience, who is this? Prince of Physicians. Sorry, he was a sort of contemporary of Al-Razi. Ibn Sina is the correct answer. Ibn Sina or Avicenna. Okay, Team C has got it correct. So they get 20 marks. I see that you are not using your lifelines. Please use your lifelines more. Okay. So the last question to Team F. You have to identify this person, Kerala.
Dr. Keshav Nair.
Okay, correct answer. This is Dr. R. Keshav Nair. So 20 marks to Team F. So that concludes round 1. Can we have the scores now? Yeah. Mic. Because we have just 5 rounds, I think it is best that all teams have an idea about where they stand, because the coming rounds are going to be a big challenge for you to plan and carefully answer. So can we have the scores now at the end of round 1?
At the end of round 1, Team A has scored 20 points.
Okay.
Team B is yet to score any points. Team C has scored 50 points. Team D has not opened their account yet. Team E has scored 10 points. And Team F has scored 35 points.
Okay, great. So what I have to remind all the teams here is, never mind if you have not opened your score till the penultimate round. In the last round, if you answer, no matter however much the other teams have scored, you can overtake. So don't lose hope till the last round. So round 2 is on surgical anatomy. So this time we'll start from Team B. Okay, are you ready? Your question. There is a $sign. The direct question to Team B is, just identify, you have 9 incisions shown there, mostly used for neck dissections. Just identify any 2. Time. Please. Any 2 with the correct number. You have to identify with the correct number. You can see that it is written A, B, C, D, E, F, G. Just don't write the incision names. I want correct matching. Okay. So, team B has not answered. The team A wrong. Team C wrong. Team D wrong. Team F can have 20 marks. They have identified 2 correctly. So, shall I go to the bonus question? The bonus question, hands on your buzzers. You have to tell me, I hope you can all see the alphabets A, B, C, D, E, F, G, H and I. You have to tell me which among these, just tell me the alphabet, which among this is the Morestin incision. M-O-R-E-S-T-I-N, Morestin incision. Time, 10 seconds. Okay, time up. Audience, anybody? Buzzer adichu. Did anyone pass the buzzer? I didn't think. That is a timer. Okay. So, audience, anybody? Morestin incision, which one? H is the Z incision. No. The correct answer is D. D is the Morestin incision. So, I'll take you through all of them. The first one is the Attis incision. Second one is the Ecker and Bayer incision. Third one, of course, the C is the McPhee incision. D is the Morestin. E is the Conley's incision. F is the Latishevsky incision. G is the Hayes-Martin incision. H is the Z incision and I is the Barbosa. The H-shaped is the Barbosa incision. Okay. So now the next question to team C, your direct question for 20 marks coming up here. Identify the compartment shown with the name, with the eponymous name. I'll give 10 marks if you identify just the name. I'll give 10 more marks if you identify the name, the eponymous name. The first part is very simple. Just have to look at the vicinity, what are the structures forming the boundaries, and you'll be able to answer. Time up. You want to use your lifeline?
We can use the lifeline.
This round also you can use, because I see that you are not using your lifelines.
We'll use the lifeline.
Lifeline, okay. Sorry, that is the wrong answer. So you get a negative there for 5 marks, okay. So team D has answered the first part correct. It's a pretracheal compartment of Stiles, Harold Stiles, the pretracheal compartment of Harold Stiles. Okay, these are the boundaries. So team D gets 10 marks because they answered partly correct. So now the question to team D, your direct question comes up here. There is a $sign. You have to identify the vein seen in the surgical field. This is of course an axillary dissection. Just identify the vein using the other landmarks for 20 marks. Time. Other teams can write down. Okay. So let us have a look at the answers. Team B. Team B has got it correct. Team C got it correct. Team F also got it correct. Okay, scorers, please note. B, C and F get 20 marks.
Angular.
The answer is
Angular vein.
angular vein. Okay. So I think it was a direct question. Okay, fine. So no marks to the other teams. The correct answer is angular vein. 20 marks to team D. Okay. Now for the bonus question. Hands on your buzzers. open to all. There is a subclassification of level 1 axillary nodes, which is proposed by Krishna Kloh. There are 4 subzones in that classification: zone A, B, C, and D. I want you, there is a vertical landmark and a horizontal landmark in the axilla, which forms the, which divides the axilla into 4 zones. The vertical landmark is shown here. You have to tell me what it is. Okay. Did anybody press the buzzer? No. Okay. Okay. So, audience, the vertical landmark of Cloh's classification. The answer is the lateral thoracic vein. Okay, it lies just above the long thoracic nerve. Now, this is a question to team E. Direct question. Just identify the blackened out structure. What is it? For 20 marks. Time.
Lifeline.
Lifeline. Okay. Who is your lifeline? Sajumar, sir. Okay. So the other teams can write down if you know. 20 seconds or? Yeah. Okay. Collect the answers. No bonus for this question. So team E is not answering. I'll give you one more chance if you want to answer, because it was a tough question. Okay, your time's up. Audience, what is that? Anastomosis? Arterial? Both the teams, team C and team B, have got it wrong. This is the arc of, not Barkov, it's the arc of Buehler. Okay, it's the arc of Buehler. So no marks to anyone. So coming to question 5 to team F. This is a laparoscopic view of the ilioinguinal region. You can see a lot of circles, triangles. There are 2 triangles which are marked as B and C. I want you to identify. I don't want you to tell what B and C is. I want you to tell me what do you call B and C together. Yeah, you can answer if you know the answer. Yes, please. Go on. Loudly, loudly. Is that on? Is your mic on? Correct answer. It's called the trapezoid of disaster. So 20 marks to team F. Okay. So this was described by Said and Amos in 1994. So now we come to team A for the last question of the round. There is a $sign here. We come to the thyroid. So there was a question with the same picture in the prelims. So it is always wise to go back and refer, because the quizmaster may repeat the question, but a different aspect. I had asked for the connection between the superior laryngeal, the superior branch of external laryngeal and the RLN in the prelims, which is the nerve of Galen. I want you to tell me what is this other connection that is marked with a question mark. Team A for 20 marks.
Lifeline. Lifeline.
Lifeline. Okay. Lifeline. Okay. Lifeline is not answering. You still can, if you want to make a guess. No negatives. Negative is only for the buzzer. Time? Time up. You can give me the short form or the expanded form. Both will be accepted. Nerve of Reisberg, no. Nerve of Galli-Curci, no. Nerve of Joel, no. Audience? Anybody? This is the Scilab. It's called the Scilab, sympathetic inferior laryngeal anastomotic branch. The importance of this is that sometimes this branch can be very prominent and you may mistake it for a non-recurrent laryngeal nerve. The way to differentiate is, if you trace it back, you will, the non-recurrent laryngeal nerve will go to the vagus. This one will go to the sympathetic chain. Okay. Now for the bonus question, hands-on buzzers, again related to something you can maybe make out but not marked out in this picture. I want you to tell me what in a thyroid is called the Pelizo's arrow. What is called the Pelizo's arrow? What is the anatomical name or the eponymous name? Pelizo's arrow. 10 seconds. Okay. Time up. Nobody has answered. Audience? Sir? Correct answer. Tubercle of Zucker candle. The tubercle of Zucker candle is an arrow pointing to the nerve. So that is mentioned in Paley and Love. The only thing is that the reference comes from Pelizo and it's quoted in other articles as Pelizo's arrow. Okay. So now we come to the end of round 2. Scores please.
Team A has scored 20 points.
Yeah.
Team B has also scored 20 points. Team C has scored a total of 70 points. Team D has scored 30 points. Team E has scored 10 points. And Team F has scored a total of 95 points.
Okay, that's a huge lead there for Team F. Now round 3 is called the kaleidoscope. Okay, we'll start from Team C, right? Your direct question comes now for 20 marks. Look carefully. Identify the logo. This logo stands for what? For 20 marks. Other teams can write down. 20 seconds. Okay. 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 Two teams have got it correct. I want to have the correct answer from Team C if they want. No? Okay. So, audience, the answer? Cochrane collaboration. Team D and Team F gets 20 points. They have got it correct. Cochrane collaboration. Now the time for the bonus on this question. I want you to tell me what the inside of you can see there are two C's facing each other. The outer blue ones. They stand for Cochrane collaboration. Tell me what is inside the C's. Okay, Team F. For 10 marks.
Forest plot showing forest plot.
Okay, forest plot.
Showing the systematic analysis of use of corticosteroid in preterm.
Okay, I'll give it to you. Excellent answer. So this was a forest plot of one of the earliest meta-analysis, which was done on the benefit of antenatal corticosteroids in preterm infants. So that's great answering from Team F. So they get 10 points. Okay, scorers. Now, then second question to Team D. What is shown here? What is the sign, the radiologic sign? Very simple. 20 marks, no bonus. Other teams can write down. This round is very simple. Time? Okay, time up. Team D, you want to answer?
Colon cutoff sign.
Okay, they get it correct. No marks for the other teams. It's a colon cutoff sign. 20 marks to Team D. Good answer. Now to Team E. Identify just this sign. Just the name of the sign. Team E. Other teams can write down. Time. Time. Okay, time up. Sorry?
Double barrel sign.
Double barrel sign. Okay. I'll have a look at the answers quickly. Team B has got it correct. Team D, Team F. Okay, audience. That is a double duck sign. Okay, on MRCP. Team B, Team D, and Team F get 20 marks. Now, question to Team F. Identify the logo. Of what? No negatives. Only for buzzer bonus. Time? Other teams? Okay. Team F, you want to answer? What is it? What is it?
Human Genome Project.
What?
Human
Be confident in your answers.
Human Genome Project.
Correct answer. So that is the Human Genome Project. Was that a guess? Was that a guess? Oh, you're very good at guessing, it seems. So 20 marks to Team F. So now coming to Team A. There are, look carefully at this X-ray. What is shown is a triad, and there are 3 findings. I will give you the, I'll be lenient on you this time. Just give me the triad, Team A. What is this triad that is shown here? Other teams can write down. Time. There is a triad of findings in this X-ray. Use the mic, please. Collect the chits. 1 second. Collect it. Yeah, please.
Saints triad.
Sorry, that's not the Saints triad. Audience? Regler's triad. Correct answer. Let us see who has got it correct. Team D has got it correct. Team B has got it correct. That's all. Team D and Team B. You can see marked as 1 error in the. Sorry. Team D has got it correct and Team B has got it correct. Team F. Okay. Team F also has got it correct. Yeah. So 3 teams. So that's a Regler's triad. So now to Team B. Your last question for the round. This is an MR mammogram. Identify the finding. The name of the finding. It's a characteristic sign.
Linguine sign.
Correct answer. So Team B scores 20 marks there. This is the linguine sign. What is linguine? Linguine?
Ruptured.
No, what is it? Yeah, the audience has correct. It's a form of a sort of a pasta sort of thing. So it actually denotes the intracapsular rupture of the silicone breast implant. So this is called the linguine sign. So that's the end of round 3. We have 2 more rounds to go. Scores, please.
At the end of round 3, Team A has a total score of 20 points, Team B 80 points, Team C 70 points, Team D 110 points, Team E 10 points, and Team F with 185 points.
Okay, so there's a clear lead. I don't lose heart yet. The next 2 rounds are going to be very quick and you will have lot of marks to score. So the 4th round is called the quicksand. It's the rapid fire. You will have 8 questions to be answered in 40 seconds. So correct answer will fetch you 10 marks. Wrong answer -5. Right? Okay. So team who has got set A? Set A? Set A. Team F. Okay, so your set starts now. Set A. You have 40 seconds. Timer ready? Okay, set A starts. Nobel Prize in 1909 for work on pathology and surgery of thyroid. Who got it? Next. Posterior inferior cerebellar artery is a branch of. Next. Panton valine leucocidin is expressed by resistant strain of which organism? Next question. Okay. American bacteriologist who classified streptococci in 1993. All these are questions from Sabiston. So, question 5. Hypoxic cells are more sensitive to radiation than oxygenated cell. True or false? Time's running out.
True.
Okay, that's the wrong answer. Your time's up. Okay. You want to take the other questions?
Spinal cord injury without radiology.
Okay, I'll give you that. Spinal cord injury without radiographic abnormality. So they get one correct and one negative. The other answers, audience wants to answer. Delphian node, pre-laryngeal, lateral boundary of superior lumbar triangle, posterior border of internal oblique. And hypoxic cells are more sensitive to radiation. That is false. American bacteriologist, that is Lansfield, Panton Valentine leucocidin, MRSA, posterior inferior cerebellar artery, branch of vertebral artery. Nobel Prize in 1909, Coker, Theodore Coker. Okay, so who got set B? Set 2, okay, fine. So team A has got set B. Are you ready? Time. So here comes set B. Anatomist who received military cross in September 1917 for conspicuous gallantry and devotion to duty during attack. He authored a very famous anatomy textbook. Time is running out.
Pass.
Second question, first branch of IMA.
Pass.
Third question, first patient to receive penicillin. Just the name. If you don't know, you can pass. So, gene implicated in men 1. Okay. Ample, can you expand ample in trauma? What is it? It's a short form. Okay. You want to take the other two questions also? Characteristic electrolyte abnormality in refeeding syndrome. Commonest type of sarcoma breast. Okay, your time's up. Answers. Commonest type of sarcoma, angiosarcoma. Characteristic electrolyte abnormality, hypophosphatemia. Ample is allergies, medication, previous medical or surgical history, last meal, events around the injury. And gene implicated in men 1 is menin. Causative organism in Asiatic cholangitis is Clonorchis sinensis. First patient to receive penicillin was a police constable from Oxford. His name was Alexander. All this is given in Sabiston. So first branch of IMA, left colleague. Anatomist, Grant. JCB Grant. You must have heard of Grant's Atlas. Sir? Later, we'll discuss later. We'll discuss later. So set C, who has got set C? Third set. Okay, team C. Your question starts now. Founder of American College of Surgeons.
Pass.
Pass. Middle rectal artery is a branch of which artery? Ratio between type 1 and type 2 collagen in mature collagen after remodeling.
Pass.
Enterococcus, streptococcus fecalis is sensitive to cephalosporin. True or false?
False.
Okay, that is true. Correct answer. Expand IABP, the mechanical circulatory device.
Pass. Next question.
Pass. What is FDG? Give me the complete expansion. I want the complete expansion.
Fluorodeoxyglucose.
No, there are few numbers. There are few numbers.
18 FDG.
18 is always there. I want other
17,
numbers.
18 FDG.
Okay, we'll go to the other two questions also. Hanna's ulcer. Okay, lifetime risk of colorectal cancer, what percentage?
100%.
Wrong. So they get minus 5.
One more.
Lifetime risk is 80%. Hanna's ulcer is interstitial cystitis. FDG is 2-fluoro, 2-deoxy, D-glucose. Okay. IABP is intra-aortic balloon pump. The other one you got correct. Ratio is 4:1. Middle rectal artery is a branch of posterior division of internal pudendal. Founder of American College of Surgeons, Franklin Martin, the largest surgical association. So, set D. Who has got set D? Team D. Your question starts now. Time starts now. Who evolved carbolized catgut suture?
Pass.
Ascending cervical artery is a branch of.
Pass.
Drug named Magic Bullet that came up in mid 20th century.
Penicillin.
Wrong answer. Minus 5. Classical antibiotic of choice in gas gangrene. Classical antibiotic of choice. Please don't prompt. If you don't know, pass.
Pass.
Okay. Which investigation shows adder head appearance in uretrosil? In autoimmune gastritis, microadenoma develop in G cells. True or false?
True.
Okay, that's false. -5 again. Expand stir. You want to expand stir in MRI? Last question. Johnson-Demister score is used in? Okay, the answer, they got 2 minus, I think. The answer to Demister scoring, GRD, stir is short, T1 or tau inversion recovery. The false statement is because microadenoma develop in ECL, enterochromaffin-like cells. The Adderhead appearance in IV urogram. Classic antibiotic of choice is penicillin G, IV benzyl penicillin. The drug named magic bullet is sulfonamide, not penicillin. Ascending cervical artery is a branch of inferior thyroid artery. Carbolized catgut suture, Joseph Lister. Okay, so set E. Who has got set E? You have got. Okay, team B. Your time starts now. Who authored metabolic care of the surgical patient?
Pass.
Middle meningeal artery is a branch of?
Maxillary.
Correct answer. 10. Cardiovocal syndrome of recurrent laryngeal nerve palsy in mitral stenosis. I want you to give the name of the syndrome.
Pass.
What is appligraph?
Pass.
Expand meld?
Mangled extremity.
Meld? Is that your answer? You want to move on?
Move on.
Where do you use Hertel meter to measure what?
Pass.
In which animal was KIT gene first identified?
Pass.
Okay. Last, you want to answer? Which is a histologic type of bladder cancer in urachal remnant? Okay. Okay. The answer to that is adenocarcinoma. KIT gene was identified in cat. Where do you use Hertel meter? In exophthalmos, to measure exophthalmos. MELD is model for end-stage liver disease. What is appligraph? Artificial skin. Cardiovocal syndrome is Ortner syndrome. Middle meningeal artery, they got it right. Metabolic care of surgical patient by Francis D. Moore. Okay, so last set F. Who has got set F? Okay, team E has got set F. Your time starts now. Which cells in focal nodular hyperplasia take up colloid in sulfur colloid scan?
Pass.
To what angle should the table be tilted head down to facilitate filling of intrahepatic ducts on peroperative cholangiogram?
Pass.
Electrolyte abnormality in milk alkali syndrome.
Hypercalcemia.
Correct. Sign of yellowish discoloration of umbilicus in CBD rupture.
Pass.
Referred shoulder pain on inspiration in hemoperitoneum. What is that called? Eponym.
Curse.
Sorry, wrong. -5. Fitzhugh-Curtis syndrome. What is it?
Pelvic inflammatory disorder.
Sorry?
Pelvic inflammatory disease.
Yeah, what is it? What is seen?
Below the liver there will be.
Okay, perihepatitis. Give them 10. You want to answer the other two? Meckel diverticulum in hernial sac. It's called what hernia? Whose hernia?
Litter's hernia.
Litter's hernia. Plus 10. That's it. So Litter's hernia, Marshall-Marchetti Kranz procedure is for female stress urinary incontinence. Referred shoulder pain is Danforth sign. Sign of yellowish discoloration, Ransohoff. What angle? 20 degree. Which cells? Kupffer cells. I think all the teams have got the round rapid fire. That's end of round 4. Okay. So I think we can have the scores now.
At the end of round 4, Team A has 20 points, Team B has 90 points, Team C has 85 points, Team D 105 points, Team E 40 points, and Team F 190 points.
So this is the last round. We'll wind it short because of time limits, I guess. So this is called the final jeopardy. I don't think this has been tried out in any quiz anywhere in India so far. So this is a round where I will be giving you the answers. You have to tell me the question. I'll be showing you the answer. You have to tell me the question. The scores are going to be sky high. They are written there. You can score as high as 160 for a question if you get the correct question. And mind you, the statements have been framed in such a way that there is not going to be any ambiguity. The question is going to be very clear. Okay? So, which team has the lowest score?
Team A.
Team A. Okay. So, we'll start with the team which has the lowest score, Team A. You can use your lifeline also. From this entire grid, you can select, you have to tell me which part you want, which section you want, and the question mark, the marks you want to try for. The negative is going to be exactly half. You go for question 160 and you get it wrong, you are going to lose 80 marks. If it passes to the lifeline and the faculty answers correct, for 160 mark question, they will get half only. That is 80. And if they get it wrong, half of that will be lost. That is 40. Okay? And is that clear to all of you? And please don't think that the question with 160 is going to be the toughest. I have not put it like that. It may be the easiest. You never know. So, shall we start? Team A. I like to give an example of how this is going to be. I've taken it from Bau sir's book. The answer will be like this. This neck tumor is supplied by the ascending pharyngeal artery. What will be the question to that? That's from Bau sir's book. This neck tumor is supplied by the ascending pharyngeal artery. You have to give me the question to that answer. Simple. Audience? What is the blood supply of carotid body tumor? That's all. And one more thing I would like to remind you, don't answer to this question as carotid body tumor. I want it as a question. It's a test of your presence of mind and quick thinking. So give me the answer as a question. Okay, only then will you get marks. Ready? So we'll start with Team A. Lifelines also, please be ready. Team A, what do you want to take? They have how many marks now? You have 20. You can take all the 160s. Time for each question will be 15 seconds. What? Basics. Okay. Which one you want? Which one you want? Okay. 160. Okay. That's a brave choice. You're going for 160. Let us have a look at 160. The 160 question, 160 answer is going to come up. You have to be ready with the question. You have 15 seconds. Type 3 collagen is replaced by type 1 collagen in this phase of wound healing, which lasts from 3 weeks to 1 year. Think carefully. Give me the question.
Lifeline.
Lifeline. Okay. Who is your lifeline? Question. I want the question. The question which will give this answer. Correct. Okay. That's enough. That's enough. What is the mechanism what is the predominant mechanism in remodeling phase? So they have used a lifeline, they have got 80. Okay. So the lifelines have started scoring. That's great news. So your lifeline is over now. So which is we'll go back to the grid. Next team with the lowest score, please. Next team with the lowest score.
Team E.
Team E. So your option. What do you want to take? Which section? Decide fast.
GIT.
Team?
GIT.
GIT. Okay. Which question?
180.
Okay.
160.
160. There's no 180 there. Okay. We'll go for 160 question. Who is your lifeline? Lifeline ready?
Yes, sir.
Okay. So here comes your 160 answer. You have to tell me the question in 15 seconds. This anatomy classification described in 1957 was based on or rather inspired by similarity to the arrondissements or the administrative districts of Paris. Look carefully at the map and tell me what anatomy classification would be based on this. It's an anatomy classification. Just give me the question to this.
Anatomy classification describes.
That anatomy classification was derived based on similarity to this map.
The liver classification of coinoid system is resembling.
Correct answer. That's excellent answer. So this map, actually they score 160. Great answering. So this is all there is to this round. You look carefully, you'll get the answer. It almost resembles a liver. So Claude Quino, it's pronounced Quino. Claude Quino actually got inspired by this. He was a French surgeon. He got inspired by the map. Okay, so they get 160. We'll go back. Next team with the lowest score.
That would be Team C.
Okay, Team C. What do you want to go for? Which section?
Breast.
You want to go for breast. Which
160.
160. So everyone is taking brave choices now. Okay, we'll go for 160. Give me the question to this answer for 160. ACOSOG Z11 was the clinical trial which formed the basis for this clinical recommendation. What is the answer, question to this answer? The answer is ACOSOG Z11 was the clinical trial. You can use your lifeline if you want. It's probably the most famous trial in, I won't say the clue. I think it's very obvious. Should I give clue, Madhu sir? No. Huh? Organ. Organ breast ആണ്. Sentinel അല്ല breastil na choose ചെയ്തത്. Sentinel node biopsy. You want to go for it? Time up. You want to ask your lifeline?
Lifeline.
Lifeline. Team C. Can you clarify a little bit more, sir? The key point is not coming. What was the intervention that is not coming? What was compared? Versus? No, I can't give an answer to that. You're very, very, very close. You want to attempt once more, sir? Because you are so close. Axillary dissection, correct. The other part? Sorry, sir. That's not, I can't give it. They get minus 40. The answer is observation versus a completion axillary dissection for a positive sentinel node in a select early breast cancer with a low burden, low axillary burden. So we go back to the grid. Next team with the lowest score?
Team B.
B. Team B, what do you want to take?
Vascular.
Vascular. Which question you want to take?
160.
160. Okay. 160 ready. Your lifeline is ready. Okay. So here comes the 160 answer for the question. Look carefully. Double rupture comprises of Herald bleed into the lesser omental sac with transient hypotension. And then there is another rupture into the peritoneal cavity, may or may not be associated with exsanguination. This is called double rupture. This is the classic sequence of events in this aneurysm rupture. What is the question to this answer? You can use your lifeline, 15 seconds. Lifeline, you want to use lifeline? Lifeline, yes. Sir. Correct answer. So this is double rupture is what you see in splenic aneurysm rupture. So they get 80 because they use their lifeline. So the next team with the lowest score?
Team D.
Team D. Okay, team D, which I hope you are taking a note of all the questions that they have answered. Okay. Team D, what do you want to take?
Injury 160.
You want to go for injury 160. Okay, everyone is going for 160. So here comes your question for 160. Lifeline ready? What is the answer to this question? The anatomy of the posterior auricular artery explains this clinical sign, which was first described by Prescott Hewitt. This sign is also seen after hepatic encephalopathy and sometimes after fracture of the mandibular condyle. Every single person in this audience knows this sign. Sometimes the quizmaster can put distractors in the slide. So team D, I hope you are listening. You want to use your lifeline. Okay, lifeline. Who is the lifeline for team D? Bipin. Bipin. Correct answer, battle sign. That was great answering. So battle sign is actually you get that characteristic shape because it follows blood follows the posterior auricular artery. It is also seen in non-traumatic condition. There is a case report where it's seen in hepatic encephalopathy. So have all the teams attempted? One more, last.
Team F.
Okay. I think I will give it to them. That's what is battle sign. That's almost fine. So for the last question of this quiz to team F, everyone else has answered. Fine. Team F, what do you want to take? What do you want to take? Sorry?
40 basic.
40 of basics. Okay. You don't want to take the 160? No. Okay. Okay. We'll go for 40 basics then. 40 basics may not be that easy. Shall I lock on 40 basics? The last question of Science Share 2023. You want to change your option now? Time up. Pick.
40 cancer staging.
40 cancer staging. Okay.
40 basics.
Okay, if there is a confusion, do you want to ask your lifeline what to take?
Take.
Yes, Dr. Sona. Consensus. We need consensus. Lifeline. You can give your suggestion. They may take or not take. You are suggesting 40 basics. So your lifeline is telling 40 basics. You also have a role to play. So you should choose to your strength as well.
80 basics.
80 basics. Okay. So finally a good choice, I feel. So shall we go open the last answer for this quiz, Science Share 2023. So here comes the answer for 80 marks. Tell me the question. The intravascular stimulus hypothesis for this condition proposes that endotoxin release from lipopolysaccharide A triggers the release of TNF alpha from macrophages, leading to CIRS. What is the question to this answer? You can use your lifeline. Look at the keywords. You will get the answer. Time? 15 seconds. You want? Yeah, you can use your lifeline. Okay. Lifeline doesn't want to answer? Lifeline. Okay. Lifeline, if you get it correct, they get 40 marks. If you get it wrong, they lose 20 marks. You want to answer? People are hungry, Sona. You don't want to answer. Are you taking it? You're no clues. All the clues are there. Almost the answer is there. 5 seconds. 5, 4, 3, 2, 1. Answer. Not answering. Back to you. Lifeline has chosen not to answer. You can answer. Question. I want the question. Battle sign is acceptable. This is not acceptable if you don't give me a question.
What is disseminated intravascular coagulation?
Okay. Wrong answer. Minus 20. Audience? Question. Sorry, no. What is the mechanism of gram-negative septicemia? That's it. That was the question. So minus 20. With that, we come to the end of science sheet. Minus 20. Minus 40. Sorry. It was they opted to answer it. So minus 40. Minus 40 to Team F. That must have created some ripples in the marking. So let us have a look at the score. Scorers, are you ready or you need time? Are you ready? Okay, so the scorers are ready. I think we'll go to the announcement right now with the permission of the organizers. Okay. Okay. So we have finally come to the end of an exciting round of quizzing. So I think the most excitement was in the last round, which is why I told don't lose hope till the last round. A lot of things have changed in the last round. So I'll start off with the team which has come 6th. Okay. So team which has come 6th have scored 70 marks. It's GMC Trivandrum. Okay, you should have taken a little more risk. So the team who has come 5th are MOSC Kolanjeri. They have scored this is 100. They have scored 100. I'm sorry, team GMC Trivandrum scored 45. Sorry, you're not 70, 45. Team MOSC Kolanjeri, 5th, they have scored 100. The 4th place goes to team GMC Calicut. They have scored 150. They were leading for most of the rounds and finally fumbled due to some persuasion, maybe from the quizmaster. So they have scored 150 and they have ended at 4th. Now coming to the 3rd place goes to team B from Lourdes. They have scored 170. Good answering. Then 2nd place goes to team D, GMC Kottayam. They have scored 185, sorry. And the winners of Scientia 2023 with a whopping margin, I would say, from all the others except GMC Kottayam, is GMC Alleppey with 200 points. So the prizes will be announced. Prizes have been announced. It will be awarded during the valedictory function tomorrow. All the best to all of you.